Okay. Okay now. Can I just ask then, if you're not talking, to switch your camera off, please, and put yourselves onto mute. Right. On behalf of the board, Boridar, may I welcome you all to today's meeting of the Health Board, which is again being live streamed to enable members of the public to observe the meeting in real time. Members are also welcome to contribute in their language of choice, as we have Anne Clibb here to provide Welsh to English translation. We have just been through a test on that, so members all know how to use the translation facility. So thank you very much. We open the meeting then. Welcome. Apologies have been received from Mark Polin, Adrian Thomas. Claire Bodin is only available from 9:30 to 10:45, I believe. Morwenna will be slightly late in joining us. If you could please note that the Public Trustees meeting will now take place at 3 o'clock following the private board session, and a separate link has been circulated for this meeting. For that reason as well, can I ask that everyone is conscious of the time this morning? We've got a lot to get through, and we need to make sure that we obviously keep to time for the Public Trustees meeting as well. So that brings us then on to the patient story. If I hand over then to Jill first, and then I believe Matthew will be actually presenting this. Thank you.
Thank you, Lucy. And as you know, we do like to commence our board reminding ourselves of our responsibilities to our citizens and our patients. So we do have a video story, which I'm going to ask Matthew to commence.
Thank you, Jill. I'll just now share the screen and start Mr. Parry's story.
My name is Gwynfor Parry, and I am a dialysis patient at Glenclwyd Hospital. Yeah.
And I'm Julia Parry, wife of Gwynfor.
This year, as things are opening up and my ploughing entries are starting to come in now, I would like to have my weekends to go to and compete in these ploughing matches, which are held on Saturdays and Sundays in various places. As I am quite fit and able to do my ploughing, and that is thanks to dialysis.
I was just going to say that.
Dialysis team.
Thanks to dialysis.
Thank you very much.
Yeah.
You know, you've given me an extra lease of life.
Yes.
And I feel well, and I would like to use it to the best means that I can.
Yeah.
And in August of this year, we hope to do all celebrations with a family that we couldn't do last year.
Yes.
And then from August into September, it will be my ploughing matches, which will take up weekends again until middle to late October. And if I keep as well as I am now, I will be certainly looking forward to the British national competition
representing Wales
yes. At the British Nationals, yes. Which will be held at yes. Chatsworth House.
Yeah.
We've got a motorhome, and we like to go on weekends out to Anglesey and the Lake District and up to York. Lovely places that we have been able to. While I was attached to the renal unit, we were still able to go to all them places. But dialysis is different. It's tied me down to the ward in Glenclwyd 3 times a week.
And
when I'm
COVID.
not able to have the weekends off, well, it's not as easy, is it? I don't think I could cope with the machine myself, being of the older generation. I'm not like the youngsters, which are computer savvies, and so that is why I had to choose to go on fistula and go on to the dialysis ward. It was a big shock to have to go on dialysis, and I felt, well,
I remember you saying to me, oh, thank goodness, I'm nearly 80. I
yeah,
feel for anyone who's nearly 30,
yes,
you know, happening to a youngster.
I have been very lucky that the renal team kept me with medication for such a long time without having to go on dialysis. We felt that we were on our own.
Yes.
When we asked to change shifts, and the answer came back, no, it is impossible to change shifts. They say it's very difficult to change shifts, you know, and all they can. I was looking forward to a Monday afternoon, Wednesday afternoon, and a Friday afternoon, but the people in charge of the ward say that is impossible because it is ambulance bringing in much poorer patients than myself for the afternoon. They are not able to come in for the morning shift, which is 7 o'clock in the morning, which is too early for a lot of patients that's poorly. So I understand that. The reason I want to be on the afternoon shift for the winter months is because of where we live and the conditions of the road. Narrow roads which never see a gritter up here, only on the main roads between Abergele, Llanfydd and Llangernew, Llanrwst, the main roads. But to get down to the main roads, I've got about 2.5 miles of steep hills down, steep hills up, and narrow.
Yeah.
And when they are covered with ice on the mornings, it is not safe, even with a 4x4. But I don't feel like selling up here and moving down to Abergele, to a bungalow, to be on a good road to go to dialysis in Glenclwyd. This is where I was born and bred, and I hope to die here.
I'm Liz, I'm the dialysis unit manager here at Glenclwyd. We're extremely busy at the moment, as are most dialysis units. We take on so many more patients now, and especially with much higher comorbidities. We dialyse currently on a Monday, Wednesday, Friday morning, afternoon and a twilight shift which runs till midnight, and on a Tuesday, Thursday, Saturday we dialyse from 7 AM in the morning until 7 PM with 2 shifts. So it does give some flexibility for patients, but it's the transport aspect that quite often makes things quite difficult. At the moment, any patient with a mobility level above being able to get in and out of a car unaided can only travel via ambulance with a dedicated crew, and they only actually supply as ambulances on a Monday, Wednesday and Friday afternoon. As you can imagine, it does put pressure on the service. It does then limit what shifts patients can dialyse on. Some patients don't want to dialyse on a Monday afternoon, but they have to because that is the only transport they can get, and vice versa. There's patients who want to dialyse on a Monday but can't because we can only take patients requiring ambulance transport because we don't have the 6-day service. We do try our utmost to give them the dialysis shift that will suit not only them but their family and their carers. A lot will have caring responsibilities for the family members, not alone them needing carers as well. So there's a lot to take in and to think about. Additionally, now when we have new starters, we really do have to plan ahead to think where will they be able to dialyse, to be able to get in and out safely, and to still maintain a quality of life really that we want them to carry on with. Dialysis mustn't be the end of their fun and their life that they want to get on with. The lack of the 6-day service for patients also leaves a high acuity for staff on the Monday, Wednesday, Friday afternoon shift, because the patients that do attend on that shift tend to need a lot more assistance with their mobility. A lot will have had major surgery and are unable to walk, have to come with ambulance and wheelchairs, and some even have to come on stretchers. So for staff, they have all the patients who have the higher acuity of care all on one shift. Ideally, these patients should have the option, and they should be across all 6 shifts, the afternoon shifts, and that would actually make it better as far as patient safety goes as well for staff. The other thing which is very high on the agenda with dialysis, and we're doing very well here with building our service, is the home haemodialysis. Any patient who shows an interest, we will fully support them to go home. We have a home therapies team. We also have self-care on the unit. So patients who perhaps want to do a little bit more of the care but don't actually want to go on home dialysis, we fully encourage that, and that just gives them that little bit of independence going forward. It's not every patient's cup of tea, they don't all want to do that, but that option is there if they want. With the current limitations of only the 5-day service for ambulance, we have to keep spaces on that Monday, Wednesday, Friday afternoon shift. A minimum of 2 spaces for patient safety. Any patients that may suddenly decline in health and have to change shifts from one of the other shifts. Any patient that's been admitted to hospital and their mobility has declined while they've been in, then on discharge they would need to start on that Monday, Wednesday, Friday afternoon shift. I can't emphasise enough that the 6-day service would enhance patient choice and satisfaction, along with improving patient safety by reducing the acuity on the Monday, Wednesday, Friday shift. On the unit, all the staff are dedicated to our patients, and what we want is for them to be happy coming in. It's not what most of them want, but if we can make their time on the unit as fun as we can, then that's what we like to achieve.
Thank you, and that concludes Mr. Parry's story, and I'd like to thank Mr. Parry and Mrs. Parry for taking the time to share their story with us. I'd just like to remind the board as well that as part of the digital patient story project that I started, we've now moved towards providing audio and now video-based stories for the board, which I think enhances the patient voice here in the board meeting and provides more a direct view from the patients themselves. The accompanying paper outlines some of the changes that have been made. In particular, we've shared this story with a range of services involved in Mr. Parry's care across renal and dialysis services. We've also worked collaboratively with our partners in Welsh Ambulance Service Trust to share their story. It was presented at their quality committee in November. As a result of Mr. Parry's story, WASP colleagues have submitted a business case to Welsh Government to extend the service to 6 days. And they're currently waiting the outcome of that bid. And I am pleased to say that the service, working with WASP colleagues, have been able to accommodate the changes in shifts that Mr. Parry wished, and his preferred pattern has now been accommodated. Thank you, colleagues. That concludes the patient story.
Thank you, Matthew. And just to add, can we wish Mr. Parry all the best in his competitions as well? Thank you.
Thanks, Jill and Matthew. And yes, indeed, we do wish him all the very best. Cheryl.
Thank you, Chair. Just to say what a fantastic way to start the meeting, and it reminds us why we're all here, doesn't it? What a wonderful patient, and what a great reaction from our service to be able to help him live the most of his life. What a wonderful life. Thank you very much.
Thank you, Cheryl. Yes, indeed. What can I just ask about the state then of the service across the whole of North Wales in relation to the how it's been described, please?
Yes, Lucy. So the service at the moment runs 5 days a week as outlined in the video, but there are set shifts to bring staff into the services, and they tend to operate fixed patterns. So it is a similar pattern across North Wales as what's been described here in the video. And some of the limitations is being able to accommodate patient preference because of the availability of the service and the need to maintain some flexibility and some vacant slots within the service to accommodate any urgent prioritisations that need to be made. So the hope for the bids around the 6-day services, it will provide a greater service for the population across all of North Wales.
Thank you. And we provide home dialysis as well, don't we? So is that being measured against the 6-day service to provide an option?
Yes, so the home dialysis service operates. I think Mr. Parry chose not to take up that particular service, and it wouldn't be appropriate in all cases for all patients. But that is certainly an additional offer. The story from Mr. Parry is very much about the service to bring him into the centre at Glenclwyd.
Thank you very much for that. Okay, there don't seem to be any other comments, so we will move then on to if there are any declarations of interest. And I can't see any hands, so we'll then move on to the draft minutes of the Health Board meeting held in public on the 18th of November. Are there any issues of accuracy? Are we happy then to note for accept the minutes for accuracy?
Yes. Yes.
Thank you. We then move on to the action log then. So the first action then on page 1 and going on to page 2, this was around the primary care indicators that had been requested to be put into the quality performance report. And the update states that the quality performance indicators have some primary care measures have actually been included now in the quality performance report. Now, these indicators have not actually been shared or discussed or included as described, unfortunately. And board members will be aware that this has been going on for quite some time as an outstanding request from the board. And we've had a commitment this will be the 4th board meeting now that this has been raised. And we've had previous commitments made that this would be addressed. Not only is it still not addressed, but we have an update now to the board, which is also inaccurate. Which is particularly worrying because we should be able to rely on the information that we've been given in relation to these updates. So given those two factors, could I ask then, please, what is going to be done about this? To make sure, A, the updates in future will be accurate, and B, that actually this is going to be addressed. Sue.
Thank you, Lucy. So, as you know, we are doing a number of pieces of work around improving the robustness of the report. Effectively, it is a very manual report that is pulled from lots of different sources of information. And we've got a plan in place to make sure that for the beginning of the new financial year, we have both a quality report, and it's worth talking about the OPMR report at the same time because it's around the suite of performance reporting that we do provide to the board and committees. We've done a couple of workshops, both with the relevant committee chairs on both of those reports to make sure that we are meeting the needs of the committee and we are aware of, you know, the different requirements from those committees and also from the board. So I am working very closely with our ICT colleagues and with the performance team to make sure that we improve both the quality of the report and the relevant nature of the metrics that are included in it. In terms of the primary care measures, we did include primary care measures around dental, prescribing, vaccination, and other metrics relating to primary care. But I guess from my understanding, Lucy, the main request was around GP measures, and that is the bit that we have struggled to provide additional information for the board. We did produce a report when you asked for it in November that talked about a proposal around what primary care measures could come through. They did a piece of work with the Assistant Director of Primary Care about what measures were reported in the area teams. And unfortunately, that wasn't sent to you and to John as chair of PFIG, which is, so I apologise for that. It was just a mistake with a handover of staff that we were told it had been done and it hadn't. So I apologise completely for that. I will take personal action to make sure that we have a conversation, you and I, Lucy, and also I'll include John in that as well, around the measures that we now know are reported in the area teams, to make sure that we include that in the next report. And I will get that, because of the urgency around it and the fact it's been raised a couple of times, I'll make sure that we have something by the end of this week to you.
So this particular issue, Sue, is nothing to do with the report itself being manual. The point is, this is the 4th public board meeting now that I've had to raise this as an issue. In addition to that, I have had, I think, about 5 meetings outside of the board to try and address this. This is the 4th public board meeting where a commitment has been made to address it. And yet still it has not been addressed. But more importantly for me, we've got an action log before us that says that it has been dealt with, and it hasn't. As I indicated to you before the meeting, I can't see any primary care measures at all, as you've just described, in the quality performance report. Joe, can I bring you in, please?
Hear you.
Joe, can I bring you in, please? You're on mute, Joe.
Apologies. Of course, Lucy and colleagues, I'd like to apologise on behalf of the executives. It's really disappointing to us all to hear your disappointment and frustration. Sue has committed personally to work with colleagues, yourself and John, to seek a resolution to this long-standing issue. And I support Sue and colleagues in their endeavours to get this right, not only for yourselves as executive members, but for the record. It's important that we're able to place reliance on the information that is provided, and that we are always accurate in our responses on action logs and within the information we provide. We had put a number of second checks into the process associated with the production of the reports. Clearly, we need to go back into the business and further strengthen those existing quality checks. As you will know and understand, some of the solutions to these challenges are associated with a move away from a reliance on a series of manually inputted data flows. Not an excuse, but it is a change that we would intend would enable us all to place much stronger reliance on systems and processes rather than on human factors. So an absolute apology and a commitment that this won't need to be raised at a future board meeting. Thank you.
Thank you, Joe. John.
Thanks, Lucy. I think for me, just to concur, it's concerning that this has been stated that it was circulated and we haven't received it. But I think for me, there are sort of 4 issues coming out to this. One is that circulation point in terms of we've got an action that's been closed, but the work hasn't been completed. We've got the issue of building in that work that was done in terms of what the measures for reporting against primary care should be to be built into the reporting. We've got a procedural one which is around the action log itself. So this work hasn't been done, so this shouldn't be closed, it should be kept open. But I think there's a other issue, which is this back to the circulation point, which is it's not the first time we've had actions closed with a suggestion that something's been circulated and then we found it hasn't been. I'm just wondering whether we can do something different to change the attention to the detail of that. By if somebody's actually insisting on something in the action log, if somebody says it's been circulated, we need to know date and time as to when it was circulated to try and force that visibility and allow us to check more easily whether something has actually been circulated to people for comment and analysis and review. Thanks, Lucy.
Thank you, John. Yes, very good points there. Nick.
Thanks, Lucy. Apologies, a moment there to unmute. Reiterate the apologies from all of us that this needs to be there. We do need to get our processes right, but for me also just to we'll be there alongside Sue, working to make sure not only that the information is there, but that it's meaningful and it gives us a true understanding of what is happening in primary care, so that it really can contribute to the board's understanding of quality issues and how we can take those quality issues forward. So yes, we need to make the processes right, but in addition, you have our commitment together that we'll make sure that it's meaningful when it does come to you.
Thank you, Nick, because I mean, as you're aware, this is the reason why I've been raising this, because we need to be understanding. If we're going to look at our whole system, we need to be understanding what's going on in primary care as well, in order to triangulate our activity and our indicators. So thank you for that. Jill, you had your hand up.
I did, Lucy, but Nick has very eloquently put forward the points that I was about to make. So thank you.
Okay, thank you very much. So to conclude, I think John has raised a good point there, that whether we need to do something different in relation to this. So moving away from the indicators, actually, it's about the assurance around the information we're being given here. Can I ask then that Louise and Joe pick this up in terms of board reporting, and just see if there is a way in which we can ensure this doesn't happen again, please?
Yes. Thank you, Lucy.
Thank you. Okay, so moving on then to the next action, which is the Welsh language standards aren't due yet until March, so we move then on to the unscheduled care. This is not down for to be closed, but it is. Oh yes, sorry, apologies. Winter plan is on the agenda. So the next one then is the operational plan monitoring progress report, which is down as closed. I think this has to remain open, because there has been a workshop which took place on the 14th of January, but we haven't actually agreed yet the format or the content. That was just the beginning of the journey. And looking back at the action itself, this was about to work with us to resolve reporting concerns. So I think this needs to remain open. Do we have a time frame, Sue, please? You're on mute, Sue.
Sorry, Lucy. What we've agreed is that the new report will be available for the reporting of the new financial year. But in terms of the actions from the workshop last week, we agreed that I would share sort of the outcomes from the workshop with you this week, and that we would try and have a draft of the report for March. So I'm happy to reopen the action and put a March deadline on it, if that's okay with you.
Thank you. Yes, that's noted then. Moving then on to the next action on page 4, the Vascular 178.2. Process learning review has been initiated and will inform the board any operational teams on the implementation of future service development. Can I ask Louise please to update on this, because we've actually discussed this needs to be moved forward before we can actually close this action down.
Thank you, Chair. Yeah, happy to, and also Nick may want to comment as well because he's the executive lead in that review. The Good Governance Institute have been commissioned and are taking forward that review right now. The report is due towards the end of January, and there will be some discussions needed about where we take that report to, and then how we spread the sort of messages and the monitoring of the recommendations thereafter. So that is something that's quite live. We're just waiting for the final review, which will conclude, as I say, towards the end of January. But Nick is the executive lead in that, so may want to comment further.
Thanks, Louise. Nick?
Thank you, Lucy. I think Louise has just updated. I suspect, I'm afraid, there may be some delays. Some of the interviews with key clinicians have been delayed, not through any fault of Good Governance Institute, because of the clinical workload responding to the pandemic. So whilst the initial completion was end of January, I suspect it's more likely to be the middle of February. But I concur with everything that's been said. This is really important in driving forward our learning from the vascular experience.
Thank you, Nick. Can I suggest then that we put we keep this open, but get a further update in March? And I think what we need from the board meeting, the update to the board meeting, is about where basically it's going to go, what the timescales are for the completion of the review, and where it will then be reported to, so that we can make sure that it's included in the cycle of business. Because I appreciate it doesn't necessarily need to come to board in relation to those learning, but we just need to agree exactly where it's going to be landed. Okay. Joe.
Lucy, thank you. In addition, it would be useful to note for the action log that we would also be seeking to distill lessons learned, and be starting to think about how we can apply any improvements from the learning process as part of that update in March. Thank you.
Thanks, Joe. I skipped past the finance action on page 3 as it was down as closed. Richard, did you have a comment on that?
Yes. Sorry, just fiddling with the controls. Yes, I'd like to query whether that is something that should be closed at this time. Savings plans and the delivery of them are clearly something that is critical to our future good management. And I note that the original objective of this particular matter was to consider how to best provide assurance to members that savings were linked to transformation. A question, has that actually happened? I appreciate that there is a section in the routine finance report that's entitled savings, but I'm not entirely convinced I've seen anything that effectively links savings plans with transformation and delivery of balanced finances. Nor with anything that demonstrates the effective delivery of those savings plans. So I'm not entirely sure whether or not that should be closed at this point. I also note that in the documentation that we've got, that Mark requested that the matter be presented to the board in January. Unless I'm having a senior moment, maybe senile moment's more appropriate. I'm not sure I can see it on the agenda. Could Sue perhaps point out to me where there is a paper that sets out how the savings plan is to be constructed and relates to other documentation and to deliver an effective message to the board. Thanks.
Thank you, Richard. Yes, you are right. The previous action update was the action to be reopened. The chair indicated that he would wish to see the matter presented to board in January. And then the latest one is about the timetable for submission being extended, which doesn't actually address the request of the chair previously. Sue. You're on mute, Sue.
Thank you both. Just in terms of the savings programme, the timetable we produced only allowed for the savings to be ready for the end of January. So because we're doing the timetables moved, and we are talking around the finance plan in detail in the workshop next week, we've moved that forward so that it's going to go to that PFIG for discussion and review before we take it to the board.
Okay, going back to the original action though, Sue, it was about ensuring visibility and confidence in the savings plans. I think that's the point Richard's making.
Yeah, so I think I'm agreeing that we will reopen the action, Lucy, and then I will work with Richard to agree how we can provide that confidence around the process itself.
Thank you. Richard, are you content with that?
I am, although I'm not. I think maybe this links to the previous discussion on an item further up this report as to how and why things become closed when actually they haven't been closed. I'm more than happy to take this forward with Sue. That's very welcome. But I think there is a genuine issue here about how things get closed off on this report when actually there's not been any closure. I'm also a bit concerned that nothing is on here this month of any significance, despite the chair having asked for it. I'm happy to take the assurances.
Thank you, Richard. Yes, this does clearly need to be addressed. Can we make sure that's recorded? Thank you. Moving then on to the next item on page 4, which is review of meeting effectiveness. I know there's been some work going on with that. Louise, can I ask for an update, please?
Yes, thank you, Chair. Yes, this is a quite longitudinal action, as colleagues will appreciate, and principally we're taking forward this work via the work stream that's been developed following our board development sessions in October, which is principally looking at reviewing committee effectiveness and how we can make our improve the quality of input and output from committees, which will then inform the information that flows up to the board. So, Chair, if it is acceptable to board members, I would ask that we keep this open, but also extend the time frame if that's acceptable. We will be talking a little bit more about the output from the work streams at our next board development in the middle of February. But if we could keep it open for review further at the March board meeting, I feel like we will have more evidence of the progress that we're making with that action.
Thank you for that, Louise. Yes, I think we can extend that. And could we also make sure that we perhaps bring them into the discussion that we've just had in relation to reporting to the board? Thank you. So going then on to the next action that is due. In fact, none of the actions now are due to be closed now. However, I would like to note again, bottom of page 6 on the 21222.4 quality and performance reporting. Again, for the record, please can we correct that update and reopen that action, please, because the indicators have not been shared and included in the report as we've previously discussed. Are there any other actions down as closed that anyone wishes to raise? No. Okay, thank you. In which case we will move on then to briefing notes for members. There's nothing to note in relation to this agenda item, so that brings us to the report of the chair. So I need to record the following chair's actions. The board chair's action to accept approval of the purchase of replacement linear accelerator and auxiliary equipment, subject to the approval and provision of funding by Welsh Government. And second, there was a dual PFIG and board chairs action to approve imaging equipment replacement BJC, so that the Health Board can immediately proceed with placing the MR scanner order with Siemens Healthcare Limited and enable delivery and expenditure prior to the 31st of the 3rd. And we also have some items on the agenda today as well. The Chief Executive and Chair continue to meet regularly with stakeholders and political partners to provide briefings on COVID and other matters. And there's also a meeting with the Deputy Minister later this afternoon to discuss mental health services and targeted intervention. This particular meeting this afternoon will be the first of a series of meetings that are planned on a quarterly basis as an opportunity for the Deputy Minister to be appraised of improvements and challenges faced by our mental health services. Any questions or comments? Thank you, in which case we move on to the report of the Chief Executive. Over to you, Jo.
Thank you, Chair. For the purposes of brevity, I'm very happy to take the Chief Executive's report as read. I would like to inform board colleagues that during the period of time, particularly associated with the pressures on the service aligned to Omicron, the Chair and I, with support from colleagues, have been meeting regularly with regularly with MS and MP colleagues in order to provide them with an update on our vaccination booster programme, which has been rolled out very successfully and very smoothly. Thank you to all of our colleagues who have worked incredibly hard on that over the most recent period, but also to provide an update on the impact that Omicron is having on the assorted services we provide, whether that's test and trace, inpatient support, including ICU for those patients who unfortunately are in need of that support across outpatients and into primary care. I'm very happy to take any questions or clarifications on my Chief Executive report, which as usual provides an insight into the range of activities across the organisation as a whole. Thank you very much.
Thank you, Jo. Lynn first, please.
Thank you, Jo. There is an enormous amount of information in your report, and may I praise you for all the achievements that have taken place during a very difficult period. Could you just maybe spend a little time on the organ donation and transplantation? Because that seems to be such a success and such a difficult time we're going through.
Yes. When a person is in a situation where it might be clinically appropriate for there to be a donation of organs or an organ, regardless excuse me, Lynn, regardless of whether that individual has indicated that they're committed via the organ donation registry, there's obviously an awful lot of work that our clinicians need to do with family members or others who may need to be involved in those conversations. And it is always pleasing to see the percentages of suitable organs for donation translating into actual donations for recipients As you will all know, the numbers of people in the UK who are waiting for organ donation always are large, and always are incredibly grateful for those donations should they be successful. It's a real testament to the skills of those clinicians who are able to have the hardest conversations, and then who are able to support families and the patients through the process of organ donation, retrieval, and then successful transplantation. It's a real success, and very pleasing to see. Thank you, Lynn.
Thank you.
Thank you. Over to John.
Yeah, thank you, Joe, for the report there. Just want to pick up on the Welsh Government recommendation of the 100 more surge beds. What's the current position with regard to that? Is there still going to be that type of demand potentially in the system, or are we now looking at diminishing numbers? And if there is that need for the 100 additional beds, is there any progress at all around whether an MFIS will now need to be reopened, and also the implications on the staffing for 100 surge beds? Thank you.
John, and with the Chair's support, I'd like to defer responding to that question, as we have an opportunity to provide a COVID update more fully later on in the agenda. Work is well progressing with regard to the requirement for surge beds, both in terms of number and location, but that will be part of a more fuller update later on in the agenda with your support and that of the Chair. I'm sure Jill will cover that later on.
Okay, that's fine, thanks.
Of course, we've got the winter plan on the agenda as well, which talks about the surge capacity. So we'll defer that to the relevant items. Medwyn.
Thanks, Chair, and thanks, Joe, for that very comprehensive report. I'm looking at the regional treatment centres. Basically, a question on timeline here. You're going through the formal tender process next week, I would imagine, or unless you've already began, and then you're going to hopefully supply identify the preferred supplier in April. If things go to plan, when can we expect that this regional treatment centre will be up and running? I think that's my question. I'm not sure if you've frozen or not.
Are you still there, Joe? No, I think we've lost Joe. Jill, would you be able to assist with that, please?
Yes, I can provide an update, and we are, for your information, we are trying to pull together a brief to share with the board in terms where we are up to. In terms of the tender process, we have got a number of expressions of interest. We've had a number of we've had some open days with those people who are interested. We are now following through with Welsh Government colleagues, and indeed with our own procurement and legal teams, the next steps. Because of the sensitivities around that, Medwyn, I'm more than happy to have a conversation with you outside, but the brief and the timeline is being pulled together. It is indicative on the current timeline.
That means that when somebody speaks Welsh.
Sorry?
So if you're not speaking, can you go on to mute, please?
Sorry, just to continue. At the moment, the timeline is for award of the tender at the end of March, beginning of April, but that is subject to just clarifying some legal points around procurement.
Thank you. And I would imagine running parallel to that are the staffing implications for these centres?
Absolutely. So again, what we're working with potential suppliers in terms of the blended model supported that we've described to the board previously.
And everything's on track. They're both in sync. That's what I'm saying.
They are in sync, but as I say, there are a couple of hurdles that we just need to ensure that we are going through the appropriate processes and it can go smoothly.
Thank you.
It probably is worth, alongside that, Medwin, describing the parallel pieces of work with the RTC. As we've said before, this isn't just about buildings, it is about pathways. So with Chris's team's support, that piece of work is already beginning to take place, and indeed we've got a clinical event, I think it's next month actually, regarding orthopaedic, the Getting It Right First Time pathways, which is running in parallel. So yes, the RTC tender work is going forward, but alongside that, the transformation piece, working with our clinical colleagues.
Thanks very much. Thanks.
Thank you for that. So we go now on to the targeted intervention improvement framework. We're asked to note the progress in delivering targeted improvement within the report. If it's okay, Jill, I'll go straight to questions. Are there any questions or comments? No, I can't see any. So in which case we're asked to note the report, the ministerial letter and the response from the chair as well is of course in the papers too. Is there anything further you wanted to say, Jill?
Just two things if I may. It's already been alluded to by yourself, Lucy, regarding the ministerial meeting this afternoon linked to mental health and targeted intervention. The other point I'd like to make is that we are already in preparation for the next Welsh Government meeting, and you'll note from the report that we have passed the engagement lead over to Helen Stevens-Jones now that she is in post, to ensure we've got a clear governance structure.
Thank you, Jill. Okay, so moving then on to the COVID update, which I believe Chris is going to bring up on the screen now. So this paper was circulated yesterday following the most recent Gold meeting, which took place earlier that day. So this was to ensure that attendees had the most up-to-date information. So apologies for the lateness of this being published, but it is the information is changing so rapidly that we want to make sure that we have the most up-to-date information. So over to you, Jill. Thank you.
Thank you, Chair. Before we go into the slides, I'd just bring your attention to the cover sheet, which actually does provide an overview of some of the decisions that have been taken in the Gold, following support from Silva and colleagues across the Health Board in providing us with information. They are articulated within the paper, and I will also pick up the point which is alluded to regarding the MVIS. We have done a piece of work, teams have done a piece of work with local authority colleagues looking at the potential to step up the MVIS. There is significant risk with that happening. There are significant risks with that happening, and as a consequence, that work is paused. It's already been called out, the risk around staffing, given that the area that we were considering is also one of our vaccination centres. It would have compromised the use for as currently as a size of mass vaccination centre. So that piece of work has been put on hold, but we do know what plans are required should there be a need to escalate that. So it's just to answer John's question from earlier. So if we can go through the slides. Thank you, Chris. We can go. So what you will see here is the executive summary of where we are against the daily cases that we've seen, and you'll see a significant drop off in January. I think Teresa is in the board, and I think she will support me in saying that we need to be really careful, and we're watching really carefully the drop-off that we've seen in the last few weeks. We are really hopeful that this is positive news, but given that we have moved quite significantly towards lateral flow testing, and indeed we know that our students and children are going back to school, college and school, we are watching these numbers closely. In terms of confirmed numbers, you can see the numbers on the slide there. Again, we are monitoring those closely. Next slide, please, Chris. Again, I think this reiterates the point that we're making around the positives, and you can see the amount of testing that is taking place, and you can also see in the map where we're seeing a higher incidence of cases. The slide also demonstrates the age bands that we are seeing, and again you can see that this is we are seeing a focus in the lower age groups. Moving on, Chris. The slide articulates where we are in terms of healthcare acquired infection status. We are working really closely with colleagues to ensure that we are maintaining the best IPC procedures that we can put in place. The nature of Omicron and its transmission is certainly, we are seeing an impact of that, but what we are seeing is that these where we do have outbreaks, they are not, and you'll see this later in the IPC update, they are not, they are being shut down quite quickly, and they're not escalating into a level 3. Next slide, please. What this slide is showing you is the hospital occupancy, and you'll see that that is extremely hot across all of our areas, and this is having an impact on our ability to deliver planned care. We are developing emerging plans to turn on as much of our planned care as possible, and we are currently monitoring that via Gold on a week-by-week basis. Next slide, please, Chris. You can see the differences here between our first waves of COVID and what we're seeing with the Omicron variant. We are not seeing the same level of critical care occupancy, which is really good news. We do have strong critical care surge plans in place that have been pulled together with our clinicians that are ready to go should we require it, but at the moment our critical care occupancy is coping well with the pressures we are seeing, but we are cognizant that we are in a difficult winter as well, so you'll see that the green occupancy, i.e. those that are non-COVID, is high. Thank you. This has been a subject of discussion at a number of boards, and it does identify where we are working with on patients that we term are medically fit for discharge, and those are patients that perhaps don't need the acute interventions that are provided within our hospital care settings. The piece of work that we have done across North Wales is to articulate and break down which one of those within our gift and which one of those that are not within our gift, but we're working really closely with partners, recognising their own pressures in terms of, particularly in terms of staffing at the moment. Again, I think the chairman requested that we articulate what the pressures are within the hospital system on a more long-term basis, and what you can see from this is that we are consistently in the level 3 and the level 4, and this is despite the fact that we currently have 150 beds escalated across the 150 beds plus escalated across the health board. So these are beds that would not normally be not normally be in operation. I think the other point to say there is we're really conscious that when we are in these situations, it is having an impact on our ambulance service, and we're really conscious of the fact that that is not necessarily allowing ambulances to be released to those people that most need them in our communities. So we're working really closely with our ambulance colleagues to see what mechanisms we can put in place here. And just yesterday, the executives were hearing about a escalation mechanism that we are looking at putting in place across the health board, which I'll pick up as part of the winter plan. I would like to thank our staff, because these are really difficult times at the moment, and they are stepping up, and we are stretching our staffing quite acutely to be able to maintain safety across the organisation. Thanks, Chris. This slide demonstrates where we are against the national modelling, so the Swansea modelling. I think it's quite evident that in many areas we've been following this quite closely. Chris. We have been asked to articulate where we're seeing general practice escalation and pharmacy escalation, working really closely with our GPs and our primary care colleagues, and indeed our pharmacies, to ensure that we are providing those services that our citizens need. I'd also like to call out that during all of this time, both our pharmacies and our primary care colleagues have been supporting the vaccination programme. Thank you. The key risk that we're facing across a number of areas has been our workforce. And you'll see from this graph the absence that was related to COVID isolation, or indeed COVID positive amongst our staff, and it has been significant and has been on top of our normal staff absence. So what you can see there is nurse and midwifery absence has been up above 7%, clinical services above nearly 10%. So that has had a significant impact on our ability to deliver services across the organisation. You will see that has dipped a little bit. We're watching that again really closely, but we are hopeful that the new measures have been put in place are having an impact and allowing our staff to return earlier from isolation. Okay, and on a positive note, I would like to pick up the vaccination programme, and in the cover sheet it will articulate that we did step up gold and make a decision to redeploy staff to support the booster dose required prior to Christmas and before the end of 2021. So I'd like again to thank the staff and volunteers that stepped forward, including our military colleagues, to enable us to do so well against that vaccination. We are now looking to redeploy some of those staff who supported the vaccination programme across into our acute and community, to support our acute and community services. But you will see there that has been a significant success, and we are now working on the children's rollout plan. Thanks, Chris. Just in terms of a question was asked around the escalation beds, and as I've related, we do have 160 currently in use, and we have plans to open further surge beds if we can support them safely with the appropriate numbers of staff. It then becomes, that would be an additional 20 beds that we are looking at potentially opening, as I say, if we can safely staff them. Teresa, I'm sure, may want to offer some comments on the test and trace programme, because I know there have been significant discussions taking place that she's been a part of.
Thank you, Jill. If I bring Teresa in first then, and then we have some questions.
Thank you, Jill, and thank you, Chair. I'll speak in Welsh. Diolch am y diweddariad, Jill. Hoffwn ni'n ategu fel y cyfarwyddwr iechyd cyhoeddus yn diolch i'r staff reit ar draws Gogledd Cymru am eu cymorth. Nid yn unig mae gynnon ni staff yn y bwr iechyd yn gweithio ar Covid, mae yna partneriaid reit ar draws y system yma yng Ngogledd Cymru yn helpu ni, di bod wrthi ers, mae bron yn 2 flynedd erbyn hyn, da'n coelio. Wedyn, swn i'n anhoffi deud diolch wrthyn nhw. Dwi'n adlewyrchu bod ni'n dechrau
Okay, I think we've lost Teresa, unfortunately. So whilst we're waiting for her to reconnect again, I'll go to John.
Thanks, Lucy. Hi, Jill. Thanks for the report. The hospital sit rep slide was one was particularly welcomed, I think, but that's raised a question for me in terms of the timeline, because it's showing the timeline where each of the hospital sites has reached a level 2 or level 3 or a level 4, but then there's no, it's almost as if there's an immediate drop off. So if somebody's reached level 4, then subsequently there's nothing reported. It is the pattern that it does drop off straight from that escalation, or does it step down from level 4 to level 3 to 2 as a pattern? It just seemed unusual that you get to that high level and then it would suddenly drop off.
So John, this is about the way that they forgive me, but they escalate onto the system that they're at level 4 or at level 3, and that happens several times a day. So you will see that drop off. The piece of work that we're doing that I was going to pick up in the winter plan, and it's not necessarily done consistently across the patch, John, so that's something we have picked up. The piece of work that's going alongside this is we have built in, and you'll see some of this in the winter plan update or the resilience plan update, escalation triggers, which will enable that to be done in real time. So as you hit those triggers, there'll be you know this far better than I do, John, but there will be a trigger that will automatically move it up the escalation levels in more real time. But the way it's captured at the moment is it is input 3-4 times a day. So you will see this drop and.
Okay, so they're not, if they're reaching a level 4, for example, they'll log that they're at a level 4. But they're not logging that as they back off from that, they're still at level 3.
Sorry, can you so if they're at level 4 and it drops, so if the escalation level drops, we cannot guarantee that they're immediately saying that we're now at level 3, hence the escalation process that we're putting in place behind the scenes.
Okay, my question or concern was that they go from level 4. It seemed unusual that they would go from level 4 and then immediately go to level 1, which is the implication from the way I think it's represented. Doesn't.
So in terms of, I'll try and answer your question, John, and I'm more than happy to take it offline as well. And maybe that might be easier, because I think to demonstrate it might be easier.
Okay. Let's park it and have a conversation offline later.
Thank you for that. Teresa, can I bring you back in now? Hopefully you won't freeze this time.
Diolch yn fawr iawn, Cadeirydd a Jill. Apologies for my IT gremlins. I'll continue in Welsh and hope I don't freeze. Diolch I bawb sydd bod yr rhan o'r rhaglen a'r gwaith ar Covid. Wrth gwrs mae partneriaid mor bwysig a criw y bwrdd iechyd, pawb wrthi'n cyd-dynnu ar draws Gogledd Cymru, ac yn enwedig ar y gwaith TTP. Dwi'n adlewyrchu fod y cyfnod yn newid, da ni'n dechrau cyfnod newydd, dwi'n meddwl. Wrth gwrs, mae'n radda ni o ran profi di mynd lawr, Mae'r niferoedd wedi mynd lawr gymaint. Dwi'n meddwl mae nid yn unig mater o adrodd yn ôl sy'n wahanol. Dwi'n gobeithio'n dawel fod yna gwelliant o ran y niferoedd Omicron, a mae hynna'n beth positif iawn. Wrth gwrs, mae'r gwaith ar hunan ynysu, mae yna newidiadau fel dwi'n siŵr da chi gyd yn ymwybodol. Unwaith eto yn dangos wrach bod ni'n dechrau cyfnod newydd wrth i ni ddysgu fwy am Omicron, yn dal i ddysgu am Covid, ac wrth gwrs cyfleoedd newydd oherwydd y gwaith imwneiddio arbennig. Ond o'n i wedi gobeithio jyst deud mewn ffordd diolch o ran y TTP, fe oedd hi'n cyfnod hynod brysur dros Dolig. Da ni wedi gweld niferoedd tebyg drwy'r pandemig i gyd. Dyna oedd y cyfnod prysurau i ni rioed. Diolch byth mae'r niferoedd i disgyn fel oedd Jill yn adlewyrchu. Dwi yn ama fydd pethau newid o ran profi yn y dyfodol, ac wrth gwrs fydd hynna'n golygu fydda ni'n orhain yn wahanol. Ond swn i'n hoffi gorffan trwy jyst sôn am y gwaith diogelu y Protect TTP. Mae'r Protect yn hynod bwysig. Mae gynnon ni erbyn hyn 11 hwb cymorth Covid ar draws Gogledd Cymru, a dwi'n ddiolchgar iawn i'r partneriaid, boed nhw yn y trydydd sector neu yn llywodraeth leol, oherwydd diolch i nhw mae'r gwaith yna'n digwydd. Ond mae'r gwaith maen nhw'n wneud i helpu pobl i profi yn eu lleoliadau ac yn agos at eu cartra mor bwysig. Ond dwi'n ama fel bwrdd dyla ni adlewyrchu a dechrau meddwl am y dyfodol, a dechrau meddwl am renewal mewn ffordd ac ail ddechrau'r rei gwaith, oherwydd da ni yn, dwi'n meddwl, gweld cyfnod newydd yn dechrau. Mi fydd 'na chydig bach o ffordd i fynd efo'r Gwanwyn a Gaea, a dwi'n adlewyrchu bod hi'n gyfnod ffliw ar hyn o bryd hefyd, a Jill a fi'na wedi bod yn trafod ffliw dipyn go lew. Wedyn dwi'n gofyn i bawb wneud yn siŵr bod nhw yn di cael eu brechlu'n ffliw erbyn hyn. Dwi'n gobeithio bod pawb wedi cael cynnig, dwi'n siŵr. Ond hefyd bod ni'n dal ati i golchi dwylo, cadw pellter fel sy'n bosib, defnyddio masgiau, a fel mae Jill di sôn, dal i fynd arni o ran yr imwneiddio Covid hefyd. Diolch yn iawn, Cadeirydd.
Thank you for that, Teresa. Diolch yn fawr. I'll bring Medwyn in now, please.
Thanks, Chair. Just following off from Teresa there, actually, there is a relaxation of COVID measures happening across the border, and to a certain extent will happen here soon. It was interesting to hear Jill talk about the Christmas break, that the school is now back, and just wanting to sort of to underline what that might happen in terms of rates moving forward, if there's any modelling for that. No one seems to be talking about the fact that schools have had a break. Everybody's talking about the good news message coming through it, and it is good news, as John alluded to with CITREP. I'd like to go back to the death slide, if it was possible. And while someone is looking at that, looking for that slide, I'd like to also, just from a public meeting forum, as it were, in terms of the general public who might be looking here now, we are going to be looking at possibly more boosters and more jabs coming forward, and we're putting our staff who've been administering those jabs and boosters, we're bringing them back into the main core business, as it were. What plans we have moving forward? We have talked about this privately, but I'd just like to assure the public that there are plans in place that, if need be, will be have the capacity to move forward on the vaccination program should that be required. In terms of the deaths and mortality slide, my question there was, because obviously we haven't had sight of these slides before this morning, was the breakdown of people possibly, I'm not sure if it's there, of those who die with COVID or because of COVID, and whether we have any indication on that. Thank you.
Thank you. Jill, would you be able to respond to that?
I couldn't give you an answer right here, right now, Medwyn. Apologies.
Okay, it's difficult to tell from that slide what we're actually looking at. That's the problem I'm getting. But if we could sort of come back to me on that, because I think it's important for the public to know in the area that we serve, you know, what is happening in terms of the mortality rates. In terms of the other questions, then, vaccination program moving forwards, capacity moving forward, if we do, as Israel have done, bring in a fourth booster, as it were, or a fourth jab, how are we going to be rolling that out and managing that within the current system that we have?
Thank you. Chris, if you could take down the slide, sorry. In terms of the vaccination programme, Edwin, I'd like to reiterate we're not stopping the vaccination programme. We're scaling back. We had a huge requirement to boost the vaccination numbers in the period between the beginning of December and the end of December, as the board are aware and the public are aware. And can I thank all of our staff and volunteers and everyone who stepped into that space and gave up their own holidays to make that happen. What we are now doing, Medwyn, is modelling the amount of vaccinations that we are planning to do going forward. So we're not stepping down the programme, and I want to reiterate that. The programme will still be going, and I alluded to the vaccination of children moving forward. So the plans are developing for that, and we are looking at commencing that shortly. I think the point is that a number of additional staff were redeployed from other areas, including our surgical colleagues, nurses, others, AHPs, to support that intense vaccination period in that month. So it's not that we're stepping it down, it's just those people that had been redeployed to support the vaccination programme are being, I won't say redeployed back, but you understand what I'm trying to say.
Thank you. Yes, and the reason I'm asking the question is this is a public meeting, and I think some members of the public will be interested in knowing that.
No, and I would urge that they are very much open. And if you haven't had your booster, or you've not had a vaccination up until now and you want to step forward, they are very much open, and would be urging people to take up the opportunity, and would support Teresa as well in terms of the flu vaccination as well.
Thank you. The other question I had was about schools coming back, and you mentioned it. Do you see that as in 2 weeks' time we may have more of a surge, or is that a too difficult question to answer at this point in time?
I think we're watching it. I think Teresa alluded to it. I think there are very green shoots that we feel that we're entering into a different phase, but we are mindful that in previous waves that has had an impact. We've not seen anything from the immediacy of people going back to school or college, but we are watching it closely, as you would expect us to.
Thank you for that, Jill. Yeah, I do think it's important to reiterate getting your booster is probably the single most important thing that any of us can do to continue to protect everyone. The evidence is very clear that it is absolutely doing its job in relation to reducing the severity of any illness should you get COVID. So, and the vaccination programme has been phenomenal in how it's being delivered. So thank you to everyone for that. I'll bring Linda in and then Teresa back in, if that's okay. So Linda first, thank you.
Diolch Cadeirydd, ac i'r raddau mae Jill wedi ateb yn cwestiwn i trwy ateb cwestiwn Medwyn, ond dwi wedi deall yn achlysurol bod na llai o bobl yn dod i cael brechlyn neu oedd na'n amlwg, a mae'n amlwg hwyrach bod yr gwybodaeth yn y wasg, hwyrach dydy bobl ddim yn teimlo bod angen cael y brechlyn gymaint, felly mae'ch geiriau chi yn bwysig iawn. Ond dim ond eisiau gofyn os mae hyn yn rhywbeth mae Teresa and Jill wedi gweld. I'll just repeat in English because I understand we're having translation problems. I think Jill answered most of my questions through answering Medwyn, but I was interested that anecdotally, there appears locally here anyway to be appointments being missed, people not turning up to have the booster. And I just wondered if Jill or Teresa had noticed this as a trend and whether they thought that this was significant. Diolch.
Thanks. Jill, do you want to come in on that, or Teresa?
If I come in, I'm sure Teresa will support. I think I heard all of it, but I have to say, Linda, you slightly dipped out. So apologies if I don't capture all your questions. The point we continue to communicate quite strongly that the vaccination centres are open, and encouraging people and articulating the risks and the benefits that people will get from having the booster vaccines, as Lucy has articulated. We have seen people cancelling appointments, Linda, and we have been monitoring that, but the vast majority of those, I'm not saying all of them, but the vast majority of those is because we have had our walk-in centres open, and they are coming for a walk-in centre and then cancelling the appointment that they've been given. So that does show, if you like, a very high number of cancellations, but as I say, significant amount of those are down to the fact that they have taken the opportunity, and we again encourage people to do so, to have their booster or their first vaccine, whichever one it is, via a walk-in appointment, which is more convenient for them.
Thank you.
Thanks both. Teresa.
Thank you. So I was going to mention the walk-ins, Jill, so you've beaten me to it. And I'm speaking in English because I think we might have a few translation issues this afternoon, or this morning, I should say. I was just reflecting on Medwyn's earlier comments as well. So maybe I should say, I think the communications piece has been key across the region. Again, I thank partners and through the Local Resilience Forum for continually sharing our messages. But I do think that planning is important. So the SCT, the Strategic Coordinating Group, is meeting now in North Wales, which gives us really good opportunities to talk through issues in North Wales, and is through that forum that we've agreed the COVID plan for North Wales thus far. But I do know that there are national meetings looking at the future, and as a DPH, I'm certainly involved in that thinking now about potentially living with COVID in the same way that we live with flu. And we are still learning, it's still in early stages, but I do think starting to think differently and about what the future might bring. We've learned a lot through COVID. Look at flu. While I'm worried about flu for the future, we do know that the mask wearing, the isolation has meant differences. So there is work happening in that arena. There's some work streams of work on TTP because of that huge infrastructure across Wales, but equally just in terms of the messaging out to the public. And I would say we're probably in that more behavioural nudge space as well going forward. But I just thank all the public for supporting us thus far. Diolch yn fawr.
Diolch, Teresa. Thank you very much for that update. And we'll move on now to, so sorry, the board is asked to note the report and supporting presentation and endorse the decisions made by the Gold Command Operational Resilience meeting. You'll note in the paper that there are some decisions that haven't been to Cabinet. Is everyone happy to endorse those decisions?
Yes.
Thank you very much. So we move now then on to the next item, which is maintaining good governance during COVID, which is over to Louise. I'm just conscious we're a few minutes behind, so could you keep it short, please? Thank you.
Thank you, Chair. No, very happy to, and happy to take the report as read. I mean, colleagues will recognise this. It's the latest in a series of reports around maintaining our governance during the COVID pandemic that we've brought over the last couple of years. Of course, we sought to review our governance at the onset of the Omicron variant, and it details the move into the gold and silver resilience structures, as you've known, and also the work that we've done around committee work around ensuring that we're maintaining the focus on risk and assurance, but while truncating agendas and seeking to deal with other matters that we may ordinarily have brought to committee elsewhere. So it's just really an overview that keeps the board cited on all of that work. So I'm happy to leave it there and answer any questions, Chair.
Thank you, Louise. And you know, just to reiterate for members of the public, we've been trying to maintain light governance again during this difficult period. So if some of but we're making sure that if anything has been deferred on any of our committee agendas, that there's a clear trail behind that, and we're picking that up as part of the cycle of business. But in the meantime, we're trying to keep our committee meetings as short and succinct as possible to enable people to respond to the additional pressures that we're facing at the moment. Are there any questions or observations? Medwyn.
Yeah, my only observation here, Chair, would be the consent agenda, that it leads to a lack of scrutiny on possibly big decision making items within agenda setting. I think that's an important thing that we should be looking forward to in future meetings, and we should probably be learning from some of the meetings which have already taken place in terms of observers who've been at those meetings and having their feedback. I think that's an extremely important thing to learn moving forward in terms of consent agendas. Thank you very much.
Thank you. Louise, would you like to respond to that? And I can add as well.
Yeah, no, absolutely. The concept of the consent agenda is something very live for us at the moment. At least you'll probably mention about how we did look at that and trial that to an extent at the recent Quality, Safety and Experience Committee. We've also been talking to our colleagues in other organisations who use the consent agenda probably more frequently than we do, and to understand how that works and how we might apply some of that thinking to ourselves. So, Medwin, it's a very live issue. It does give us plenty of opportunities, but we would want to manage it properly. But yeah, we will keep the board apprised of how we intend to use that moving forward.
Thanks, Louise. And yes, as you say, we kind of trialled the consent agenda, but a more not in the same way as we would normally deal with it at QSE committee last week. No, sorry, 2 weeks ago. And we did actually ask that very question towards the end of the meeting when we were reviewing the meeting effectiveness as to whether or not members actually felt that they have been able to exercise sufficient scrutiny and challenge over the papers. This is something that we will pick up in the committee business management group because it is a very important point to address. So we'll discuss that and reflect upon how we can make sure that the scrutiny is maintained in a way that suits everyone. Okay, that brings us to a break then. So can I ask that we're going to take a 10-minute comfort break. So could everyone please come back at in 10 minutes? That's 11:00. Yeah, 10 minutes. Thank you. Could you please, during the break, switch your microphone and camera off as well? Thank you. Okay, so we are ready to start again. This brings us now onto the board assurance framework. So over to Louise.
Thank you, Chair. So I'm sorry, my other screen is frozen, so I haven't got the report in front of me, but I can give the high level summary. So this is the twice yearly report to the board, to cite the board on the full board assurance framework. It's coming here following a review at Audit Committee in December. And we've sought to use the report to, as I say, cite the whole board on the full board assurance framework, all 21 BAF risks. But the covering report does seek to give a particular update on the highest scoring risks that we have that are currently rated a 20. So that gives a bit more of a real-time update about those. What we've also sought to do in this report to you is explain a little bit about the process that I have discussed with a number of you, and we've had some committee discussions as well around our approach to taking forward the board assurance framework further alongside the development of the IMTP. So the work that we'll be taking forward in the next quarter will be a sort of double angle piece of work, really. One, to reset the BAF alongside the IMTP. So we're very, very clearly determining the risks to the strategic objectives of the new IMTP going forward. So they're very clearly aligned. And then a full review of the current BAF, where we will determine those existing BAF risks which will feed into the new BAF and those that may be of more an operational level. And we do know that there is a bit of a mix of those in the BAF that we've had across this year, and determining whether or not those will fall into the corporate risk register territory. So there's a little bit of detail about that work that will take place now across Q4, this quarter that we're in now, with a view to bringing a refreshed BAF to the April board workshop, and with a view to having the board, seeking the board's support with that, with detail on the review work that we will do on the existing BAF. So those are the key points I wanted to bring to the board's attention. Very happy to take any questions on the structure and the process. I would actually just mention that in the full BAF appendix to this report, I'm sorry, it's so small and very detailed information, which is a bit hard to read. And what I would commit to the board to do is that we, alongside this review work that we're doing around resetting the BAF, is actually looking at some of the structure and the presentation of the document as well, because very cognizant that it just isn't quite there really in terms of the usability. So that's just another commitment I wanted to make. So I will leave that there, but any detailed questions on the individual risks, I will defer to my executive colleagues, if that's okay.
Thank you, Louise. I'll bring Teresa in first.
Diolch yn fawr, Cadeirydd. Dim ond isio tynnu sylw'r bwrdd at wall, dwi'n ymddiheuro am y wall o fewn y gwaith papur, a mae o yn yr appendix oedd Louise yn ei drafod ŵan. Oedden ni wedi gadael allan gair a dydw i ddim isio camarwain y bwrdd o gwbl. Da ni'n sôn am y pennaeth seicoleg rŵan yn ei rôl, ond pennaeth dros dro, a dwi wedi gadael allan y gair interim neu dros dro yn y gwaith papur. Wedyn dwi'n ymddiheuro i Louise, ond hefyd i'r bwrdd yn gyffredinol. Dim ond i chi wybod, interim ydy'r rôl yna ar hyn o bryd. Diolch yn fawr.
Thank you for that clarification, Teresa. That's quite an important distinction, so we'll make sure that that's noted.
We'll amend that.
Diolch yn fawr. John.
Thanks, Lucy. Thanks, Louise, for that. I think following our discussion, I think I just wanted to support the fact that a review of how we're going to present the BAF and what's included or not, I think is welcome. One point of, I suppose, long-term concern for me is that although we created a new format, it started to appear much more like a narrative document in the responses, and I'd like to see that in a much more concise, briefer way in terms of how we recognise the actions of the gaps that we've got and the mitigations and controls. I'd also like to relate this to the next paper though as well, which is because there's a reference in there to coming back with recommendations around digital risks, but I think it will be worthwhile including those in your review to make sure that we are covering all the bases, both within the BAF and in the corporate risk register, because as you're aware, I'm still concerned that we don't lose the distinction between the different types of risks between the two, and want to make sure that the risks are recognised properly, whichever document it's in. But we just need to make sure that something doesn't get lost in that process.
Thank you for that, John. Louise, could you comment on that, please?
Yeah, no, very, very committed to that. And indeed, John, we have had a couple of discussions around this, and indeed with some of the other committee chairs and yourself, Chair. And we're very committed to working together to make sure that actually all there's a few things to line up with this, and not least that there's a specific point around some of the digital risks, John, that we've discussed, but there is that bit of that continued alignment and read across with the BAF and the corporate risk register as well. And some of the practical work we are actually taking forward next week to plan that across the two teams. That's absolutely happening. And we're very clear that once we do arrive at the new BAF, that we will have that read across. So there is confidence and assurance that none of the older risks that perhaps are of a more operational nature have been lost. So very, very cognizant of that, and we will ensure that is very clear in the new product that we bring.
Thank you for that, Louise. I just wanted to highlight, really, there's a comment on the relating to the BAF risk 2110 listening and learning, current risk rating of 20. And it talks about work continues in relation to embedding learning from lessons, claims and reviews, and that the QSE committee continues to review learning reports routinely. I just wanted to call out here, really, that the committee have received some external reports recently under the newly agreed framework, which have been of much better quality. And they should support the organisation's aim of improved learning monitoring and most importantly, evidencing change as part of being more open and transparent. There is still much to do, though, and I just wanted to make that clear in terms of the organisation being able to evidence embedded learning. And the committee are not currently assured that is being done, that is happening consistently. And I just wanted to make sure that was clear in relation to the narrative. But I support what John says there as well in making sure that this is pitched at the right level. The BAF is supposed to be different, distinct, and having said that, of course, the board are being asked to note that the proposed management of the BAF risk during Q4, and specifically that we will not be monitoring, committees will not be monitoring this in its current form whilst this process is being undertaken. But it's a short period of time we're looking at, Louise, isn't it? It's not that we're going to go 6-12 months without looking at the BAF.
No, just one quarter, Lucy, and then as is in line with the business cycles for 22-23, the BAF will be there at every committee meeting thereafter. So it is only a short period of time. And actually, through the review work, if there are things that we need to make committee aware of, we can actually still do that because the work will still continue. So we can make sure that anything that needs to be escalated actually is.
Thanks, Louise. Don't see any further hands up, so we'll then move on to the next item, which is the corporate risk register.
So if I can just open, Chair, if I may, and then I'll pass for some of the detail over to Simon. So again, we are asking the committee to note progress, and indeed I thank the team for the huge progress made with much of the detail around the corporate risk register. I think, though, it's only appropriate to note that there's a lot of work further to do in order for us as a board to really use the corporate risk register to inform our business and to provide absolute assurance around some of the mitigations and some of the detail behind it. So recognise a huge amount more work in progress. And the team working very hard have also been hampered by some key meetings being stood down due to the recent pandemic pressures. So, of course, happy to take any questions. Simon, would it be possible for you, with your permission, Chair, to guide us through some of the detail of the paper, and then happy with Simon to take any questions.
Thank you. Yes, please, Simon. But note we're tight on time. Thank you.
Okay. Thank you. Thank you, Chair. So I have done a report in the usual way that we've developed with IMs over the last period. Notwithstanding, we can always make things a little bit better. I've added in a small summary section, which I I hope colleagues are finding helpful. There are 4 new risks that have been through the QSE, which the board is being asked to take onto the Tier 1 Corporate Risk Register. One in relation to deprivation of liberty, which, although it's been through QSE, will end up with the Mental Health Capacity and Compliance Committee. One in potential non-compliance with Social Service and Wellbeing Act in Wales. One in relation to man-out handling, and one in relation to access to CAMS. I think it's useful for the board to note that the vast majority of our risks, about 2/3 of our risks, are currently sitting with QSE. And I've highlighted there the top 5 risks that we currently have in relation to care homes, clinical capacity, cybersecurity, national infrastructure, and DOLS activity, if taken on, will automatically become one of our top 5 risks. We did have the risk management group stood down, as Nick has alluded to, in November, but actions were taken through Chair's actions and through reporting into the executive. And I just want to finish with reiterating what Louise said about the links between the BAF and the Corporate Risk Register, and we are having those meetings in terms of understanding which of those BAF risks are likely to end up on the Corporate Risk Register, so that nothing is lost. That sort of preparation work is already underway. If there are questions about any of the individual specific risks, I'm sure my executive colleagues, as the risk owners, would be happy to answer them.
Thank you, Simon. I'll bring John in.
Thanks, Lucy. Thanks, Simon. I think it's just my earlier point, and it's in reference to page 4. I just wondered whether you wanted to reconsider the timescale for that, given it, CRR 27 will no doubt be part of that discussion around digital risks in the BAF as well. Because you've got a timescale of 10th of February to represent. I just wonder whether you wanted to hold off on that until we've had there's been a wider discussion.
Thank you, John. We'll take that outside so we can get back to you. Appreciate it. Thank you.
Thank you. I'll bring Richard in now.
Thank you, Lucy. Thank you, folks, for that interesting presentation on the risk register. 2 things. I mean, firstly, a general question. Could you remind me, please, how many tiers there are of risk register in general terms? What are the reporting and governance frameworks for those different tiers? And a more specific one, looking at the list of corporate risks that you've got in Appendix 2, do we have anywhere in any of the tiers a specific risk for protecting areas that should be secure from accidental or deliberate entry by members of the public, thinking about the areas that need to be clinically infection clean? There will also be pharmacies, there will be the areas where there's food production going on, and also mortuaries, on which I believe we're getting a report at some time soon. Could you just update us what the situation is on the generality of physically secure areas? Thank you.
So in answer to your first question, there are 3 tiers of risk. So very local risks or divisional risks, if you like, and corporate risks sitting at level 1. One of the jobs and roles of the risk management group is not only to look at the corporate risks in the BAF, but also to look at those tier 2 level risks and to see whether they are repeated in a number of divisions, if you like, and therefore should be escalated up. And that way we can see the rising risks. We're also testing in that when we're looking at the tier 2 risks, whether or not they can be managed at a local, at a divisional level, or whether they need further escalation and support in terms of managing the risk moving upward. So we're keeping sight on all of those risks. Through the performance management framework, risks are being looked up and down the organisation, because it's a standard agenda item on the sort of performance meeting. So that's broadly how the tierings work. In relation to the security risk, we do have security risk, but I noticed that Sue's got her hand up, and as the executive lead, she probably wants to come in before me.
Thank you, Simon. Sue?
Thanks for you, Chair. So Richard, yes, it's a simple answer. There is a security risk, as you'll have seen in the previous item, on the board assurance framework, and there are separate security risks on the corporate risk register, particularly in relation to specific areas of high risk, both on a physical level, on an individual level, so an asset level, an individual level, and on a cyber level. So there are risks. More than happy to take you through some of those risks outside of the board meeting, so that you're familiar with the infrastructure that's in place and the improvement plan that is well on its way, but still has some work to do. Thank you.
Thank you. John?
Apologies, couldn't click in. Yeah, I'm just picking up on 2116, the point there about non-compliance with manual handling. I'm not sure how your scoring actually works on the risk register, but where you've got a non-compliance, but you're actually scoring 16, surely that is, as indicated there, there's a significant risk to both staff and patients. And I just wonder what, on your scoring matrix, whether that is an appropriate one, because it does seem to be a significant problem that could cause ongoing issues until that matter is resolved. Thank you.
Thank you, John. Sue?
Okay, thank you. So the scoring, and again, John, mindful that we haven't had an opportunity to go through this, but can go through the scoring infrastructure again offline if that would be helpful. So whilst there is an element of non-compliance, there is a tolerance built in, and clearly is to our risk appetite as well in terms of non-compliance. Clearly through the pandemic, particularly face-to-face training where it's required, and that's more around individuals, so people handling and being able to assess competency, that has been severely restricted to ensure that it's COVID safe, and therefore there's been a balance of risk there. But effectively the scoring aligns with categories in the consequence or the impact, and on the basis that it's not catastrophic, i.e. it has resulted in an improvement notice, but that work is moving through, but it hasn't resulted in serious or catastrophic harm, but also as a result of the likelihood, so the likelihood of that risk impacting, that's why it's a 4x4 at this point. That is constantly reviewed, and as we move through the improvement plan, particularly for our falls piece of work, that is something that we continue to review as we move forward. But again, happy to go through some of the background if that would help.
Okay, thank you.
Thanks. Can I bring Jackie in? I know Nick's got his hand up, but if I bring Jackie in first, please.
Thanks, Lucy. Having issues raising my hand. It's a comment more than a question in terms of the way the report's written. On page 2 of 7, we say that the Quality and Safety and Experience Committee approved 4 risks for inclusion. That's not strictly speaking correct, as we weren't asked to approve the manual handling training risk. We were asked to note the recommendation from the risk management group, which is what we did at QSE committee. So it could be regarded as semantics, I suppose, but just in terms of accuracy, it should really reflect what we said at committee. And the other comment is, I know we have an awful lot of abbreviations within all the board reports, and as these are going out to the public, I think it would help that we had a glossary at some point that tells people what the abbreviations are, because our general public may not understand what we're talking about because of the abbreviations we used. Thanks, Lucy.
Thank you, Jackie. Just before I bring Nick in, because I just want to pick up on that point Jackie's just made, actually, and on the back of John's question. I think it's important to note that the non-compliance with manual handling training, it's non-compliance with manual handling training, not non-compliance with manual handling. I would actually question whether or not this the high risk here is appropriate, because if this is being compared with some of our other corporate risks, it actually wouldn't go up there in relation to when you think about the consequence. That's not to say it isn't important, of course, but I really would challenge whether or not it is actually a high risk enough to be on tier 1. But I'm going to bring, and just to say that this is something that I've raised a few times now at QSE committee, and have requested a review of the consistency of scoring across our corporate risk register, because I do think we have a problem with how the scoring is interpreted, particularly when you compare some of our clinical risks. I'll bring Nick in and then Sue.
Thank you, Chair. So in response to Jackie's comments, I don't think it is semantics. I think it's very important that we do get the language and the detail right. So thank you, and we'll ensure that's corrected in future reports. I think, Lucy, you've actually made the point I was about to make, in that I opened by alluding to the work we need to be doing around risk. And I think part of that is absolutely the consistency of assessment between the various areas, so that the board can really understand where the true risks are and the relative risk is. And I think that's absolutely key to making this report useful going forward. So rather than going into specifics, I think outside, that's the focus of much of our work. Thank you.
Thanks, Nick. That's very welcome. I'll just bring Sue back in then, and then I think we need to move on.
Thanks, Lucy. So we've had this discussion a number of times, as you've indicated, both within committee and external, and I absolutely agree that there needs to be appropriate calibration across risk. I think some of that comes from descriptors against the scoring, and I think there's more work that we could do there to make sure that they are appropriately described and appropriately weighted, and that's some work that I know Nick is looking to do, which would then help people who are scoring the risks or assessing the risk. In terms of the risk itself, and we have had this discussion particularly around the security risk, the risk in respect of manual handling training is primarily as a direct result of the enforcement action, because of the impact that was felt to have had, particularly by the Health and Safety Executive, our regulator for health and safety statutory compliance, in a number of incidents that have occurred, which have resulted in harm to our patients. So I think agree entirely around the calibration. I think there are a number of things that we can do, not least of which being really clear that the descriptors against the risk scores are appropriate and relevant, and link back to our risk appetite as an organisation. They should appropriately weighted link to the risk appetite. But I also think that there's a piece of work that needs to happen on a regular basis to calibrate. You know my view in terms of I absolutely agree. It is often difficult to get your head around as to why one risk is higher and some of our key clinical risks are lower. I don't think that's necessarily about reducing the risks that we've identified as being high. It's more about that calibration. Wrongs don't always make a right, do they? But I think that's work that we're working with members of the QSE committee and across with Nick and the risk team to get right.
Thank you, Sue. It is about around the assurance process for that consistency of scoring, which we've just alluded to, and we really must move on now. Simon, could you be very quick, please, because we're overrunning. Thanks. You're on mute, Simon.
Sorry, Chair. There's a national piece of work in terms of risk and a single risk system. Part of that work is standardisation across Wales, across risk scoring and reporting. So just so you're aware of that, there's a piece outside Betsy that's happening that we will need to align to.
Thank you, Simon. That's useful to know. Thank you. Moving on then to item for consent, which is the update against the register of section 12.2 approved doctors. Are we content to approve this?
Yes.
Thank you. Thank you. And we've got another item for consent, documents signed under seal. Again, are we content to note the list of documents?
Yes.
Yes.
Thank you very much. So that brings us then on to the winter resilience plan. So over to Jill.
Thank you very much, Chair. First of all, before we go through the report, and I am going to assume it has been read, I just want to apologise because I have reread this yet again, and I note there are a couple of typographical errors in there, so I just want to call that out and apologise up front for that. Just a couple of points I want to make. This is a resilience plan. It is described as a winter resilience plan, but I think if the pandemic has taught us anything, is our requirement to surge and escalate across the organisation can come at any time. So the principles sitting behind this are to form an ongoing resilience plan moving forward to enable business continuity. There are a couple of other points I'd like to pick out. It does pull together a number of separate plans. Some of those are seasonal, so you'll see the support for winter initiatives within the document. Also reflects the work that we are ongoing carrying out with partners as part of the RPB, but it includes our improvement plan and aligns with our escalation processes moving forward. I think there are a number of risks associated with this, some of which we've already articulated within the organisation and within the meeting today, not least that many of these plans do depend on staff, and I've already alluded in the COVID update that we are stretching our staff. They are being magnificent in terms of their flexibility in managing our safely our patients across the organisation, indeed our citizens and patients in primary care. So I just want to flag that out, that is an area that we're working very closely with Sue's team, medical colleagues, AHP colleagues across to see what can we do, not just about recruitment, but how we work differently across the organisation. This very much is working in coalescing with the work that Chris's team are doing in supporting us with the improvement plan. We continue to work closely with Welsh Government on these plans, and there is continual monitoring, and I'm happy to take any questions. I'm conscious that, and I will say that this sits in the portfolio of many of our executive teams, and they've been very supportive in enabling us to move forward on some of the plans that we're putting in place. And I've seen that number of hands up, Lucy.
Thanks, Jill. Go to John first.
Thanks, Jill, for the report. I think it highlights where we've got obviously concerns and issues and how we're dealing with those. I think the one thing that just I wanted clarification on was top of page 3 on the cover sheet talks about the financial implications, and I just wasn't sure whether this was an additional cost pressure or it was part of our existing planned expenditure.
Trying to get myself off mute here. So in terms of the winter plan, there was additional funding from Welsh Government. It's not an ongoing part of our cost pressure. These are things that we have worked on through the financial plan.
Yeah, but the Welsh Government contribution was 2 million and this was 2.8, wasn't it? So it may be, in the scheme of things, 800,000 may not be the biggest amount, but it's still, is that a gap in terms of funding?
No, you'll recall, John, that we had some funding that we allocated as part of the overall government funding to the health board.
Right, so that's what that's how it's covered. Okay.
I think Sue's coming in as well.
Thank you.
Thanks, Sue.
Thanks, Chair. Yeah, John, just to confirm, this is in the forecast for the year end, so it's not a cost pressure to the forecast.
Great, thanks, Sue.
Thank you. Lynn, next.
Thank you. I have two questions. It's clear that we desperately need to work with our local authorities, our stakeholders, and the third sector. And it is interspersed throughout this report, and especially an appendix by the RPB. I would have expected to have seen a joint risk that embodied all those stakeholders working together with us. So that's my first point. And my second point is, how do we know if all this investment and this action has been successful? Now, within the report, it does talk about reduce, better patient experience. It does give indications, but they're not indicators as to know whether the investment and our actions have been of benefit.
So in terms of the first question, Lynn, this absolutely includes input from partners in terms of the RPB, but it is our resilience plan. So I think, and we are working with other stakeholders. I think in just recently we have signed up off some work with, for example, the Red Cross as part of our stakeholder engagement. So in terms of the point around how do we make this know this makes a difference, which I think was your second point.
But can I just go back on the first point now?
Yes, of course.
Because I accept that it is our plan and it should be our risk, but I didn't see within the definitions of detailing our risks that we covered it, that we covered working with partners.
So I'll take that away, Lynn. If we haven't called it out strongly enough, I'll take that away, because I will say that as part, and we've already referred to the work we're doing with SCG, the RPB, all of the above, which is supporting us in our winter resilience. So I will take that away if we haven't called it out strongly enough, but I will, for the purposes of the minutes, record that we are working really closely with stakeholders across the patches, and indeed that's coordinated not least in terms of our COVID response and emergency preparedness over winter with SCG colleagues.
Thank you. So Mike,
do you want me to answer the second one now, if that's okay, Lynn? So in terms of how do we know this makes a difference, there are a number of indicators within the improvement plan that describe how we think this is going to be measured as making a difference, not least the escalation status that we've alluded to earlier. So we wouldn't want to be on red and amber all the time. The other indicators, and there are a number of them, Lynn, that we focus on is indeed our overall performance in terms of how long people are in our ED departments, our responsiveness to releasing ambulances, how quickly we see our patients who are presenting with us triaging, and the appropriateness of whether they're coming to us and whether we can do to divert them to a more appropriate area. So the indicators in the dashboard, we do have a dashboard that sits behind this, Lynn. I'm more than happy to navigate you through that.
No, I'm fine, as long as it was a dashboard. I just wanted a starting point to then be able to measure whether we'd increased or reduced as we'd hoped. Thank you.
Thanks, Lynn. I'll bring Cheryl in next.
Thank you, Chair. Thanks very much, Jill. Just a couple of quick questions, please. On page 19, we talk about unpaid carers, and there is the Welsh Government fund for support and information services. Could you expand on that a little, please? Because I have long-running dialogue with ministers around the support for our carers, and what they actually need is practical support, not more information. So just wondered how this is translating to actual help for our unpaid carers. Thank you. That's the first question.
Thank you, Cheryl, and I think that's a really good point, and some of that is around giving them support. I mean, the practical support element is critical. I can't describe just yet where that funding and how that funding is being used, but I think we will be working with carers carers groups to ensure that we're using that in a way that's meaningful to them within the confines.
Thanks, Jill. Yes, if we could maybe take this conversation outside when you have more information, please, because I'm not sure if this is a recycled amount of money that the Welsh Government has talked about with social care as well. And I am extremely concerned, as we all know, our carers are absolutely on their knees after 2 years of this, and its actual practical support to enable them to care for their loved ones and keep them out of hospital or resettle them back home as quickly as possible. So if we could take that outside, thank you. That was the first bit. And the second one, we talk about GP next day slots by area. What sort of buy-in have we got from our GPs on this? And more importantly, I would say the reception staff. How are we going to ensure that we get these next day GP slots? I know I have a lot of correspondence from residents about being discharged from hospital and not being able to get hold of their GP the next day, or having the appropriate discharge letter with their medication. So I think that's a really important one if we're trying to keep our beds clear. It's the buy-in from the GPs. Thank you very much.
Thank you, Cheryl. In terms of the buy-in from our GPs, clearly the support of our clusters and our GPs are going to be paramount within this. So I'm sure that Chris can give you far more detail, but actually this is something that we will be monitoring closely. I mean, we talked earlier about primary care indicators, for example.
Thanks, Chris.
Yeah, thank you, Chair. Thanks, Jill. Yes, great question, Cheryl. All of our clusters have been involved in working this through, and all of our clusters have given a commitment that this is the right thing to do. It is, of course, within the context of a huge amount of pressure and workload out there, but nonetheless, all of our clusters recognise that the opportunity from this is making sure that folk are being cared for in the best place rather than the easiest place. And as a consequence to that, I committed to making those appointments available.
Thanks very much, Chris. Any feedback we get about this afterwards would be gratefully received. Thank you, because it's all well and good, but in the practicalities of patients.
Thank you, and thanks to Jill for actually highlighting the fact that this is exactly why it's important for us to be looking at primary care indicators as well as part of our performance reporting, to provide that assurance about access to.
Sorry, Lucy, just to raise a point, I think that Joe would want to make is that the local authorities are the lead for unpaid carers, and we have allocated a significant amount of funding to be able to support them on that as well. It's articulated.
Thanks. Joe, I think you wanted to come in on this point, didn't you, before I bring Richard and John in?
For speed, I've made my comments in the sidebar, Lucy. Very happy to elaborate if required. Thank you.
Thanks, Joe. Yes, it's just confirming what Jill's just said about the local authorities, the lead for unpaid carers and resources. Thanks. Okay, over to Richard.
Thank you, Lucy. A question about section 9 on page 19. Section 9 is keeping everyone informed, and clearly effective communication with the general public about this is very important, on not just on this topic but on many other topics. You say in there that the website is being updated with details of booster vaccination availability daily. That's very good. We are also working in collaboration with partner organisations, you say, to ensure consistent messaging and a shared position on current issues. I was wondering if you could perhaps expand on exactly what that means. I mean, does it mean that if I, as a member of the public, look at my local council website, I'm likely to find health information that's useful to me being made available to me. And leading on from that, one of the areas where I do think that we could up our game a little bit, not in context specifically of this item, is our use of social media. If I was a member of the public wandering around the streets of Llangefni and I was on social media, am I likely to find messages being proactively sent to me about issues that are of concern in this and issues that I need to be aware of? Thank you.
Thanks. Jill?
Yeah, forgive me if I take those. In terms of the, I think it's the social care messaging, we do work really closely with our communication colleagues. They are very proactive at getting messages out via social media, Twitter and other mechanisms, and there are Facebook pages that our public have access to. In terms of the messaging with the local authority, we do work really closely with them. So, for example, in our strategic vaccination hub, we work with local authority colleagues who endorse and support our messaging by their own mechanisms, Richard, and we do that in a number of different fora. So there is that continuing dialogue. We recognise that our local authorities are reaching different people, very localised people, and can promote the message in different ways. So we do that. I don't know whether Cheryl or anyone would want to support that from the local authority perspective.
Thanks. Joe?
Thank you. Just to say that we have an established a group whereby the communication leads of all of the public sector organisations and ourselves in North Wales meet regularly and share information with regard to communications and social media postings in order to make sure that we're as connected and as effective as we can be. We are using targeted social media messaging already. I'm not sure whether we're so sophisticated as to follow you where you are, but we certainly are able to make sure that particular messages are targeted through social media at particular groups. We do actually have one of the most successful social media presences, if that's such a word, social media presence in terms of interest and number of hits on our social media sites, and certainly do take the lead from an all Wales point of view in terms of that particular work. So obviously always more to do, but building on a strong platform already. Very happy if Helen, perhaps not in this meeting for reasons of time, to provide some additional information with regard to the facts and figures of our communication approaches through social media. Thank you.
That would be useful. Thank you.
Thanks. We also have the Help Us to Help You campaign, which has been advertised on our website, but I'm sure there's more that can be done to raise that. I'm sure Helen's onto that already. John?
Yeah, thanks very much. I just want to pick up on the flu vaccine programme and what appeared to be some supply chain issues at times where the vaccines had not been available. Just like to clarify whether that is actually to do with BCU possibly not ordering sufficient in the first place, or is that actually a manufacturer issue and the supply into the region? Because I'm certainly aware of there were certain areas where the over 65 vaccine in particular was not available, and then there was potential offering of an under 65s vaccine and the potential clinical issues associated with that. So I just wanted some assurance really going forward that we're now going to have a handle completely on the supply chain issue, so we don't have these problems where people are waiting weeks for flu vaccines at a time when it's essential to get it as soon as possible. Thank you.
Thanks, John. Teresa?
Diolch yn iawn. Nes I fethu rhan o'r sgwrs oherwydd y glitches IT bore yma. Dwi yn dall fod yna broblemau bob blwyddyn o ran argaeledd y ffliw, yr vaccine ei hun yn y system. Da ni'n cael trafferthion yn aml ar y dechrau, ar y diwedd. Dwi'n yn ymwybodol fod gynnon ni broblemau mowr yn Betsy. Dwi'n aml fod yna broblemau wedi bod reit ar draws y system i gyd. Mae mwyafrif y pobl wedi cael ei vaccine ffliw, a dwi'n falch o'r cyfle mewn ffordd i rhoi rhywfaint o'r ystadegau i chi, oherwydd dwi'n gwybod fod o ran y pobl dros 65 oed, mae 77% o'r boblogaeth wedi cael yr vaccine ffliw. Mae hynny dros 130,000 o bobl. Ond dwi'n cytuno John, dwi'n gobeithio fydd yna ddim drafferthion yn y dyfodol wan yn y misoedd nesaf yma, tra da ni'n dal i rhoi'r vaccine ffliw. Dwi'n yn ymwybodol o unrhyw problemau ar hyn o bryd, ac wrth gwrs dwi'n ddiolchgar iawn i'n partneriaid ni yn gofal cychwynnol am eu help nhw hefo rhoi'r vaccine i'r unigolion sydd dal ar ôl heb cael nhw. So dwi'n yn ymwybodol dim byd arbennig, John.
Okay, thank you for the assurance.
Thanks very much. So just wrapping this item up then. So I think it's important to highlight that whilst the plan was cleared by the executive team in December and January, the core elements of this plan have actually been in operation for some time. In case people are thinking, well, here we are in the middle or towards the end of January now, and you know, we're seeing this. And I believe the plan is for this to be a rolling surge plan as well, that is updated each year. Am I correct there, Joe? Or Jill?
Yeah, sorry. It's intended to be a rolling plan, exactly that. I alluded to at the beginning that we've called this a winter resilience plan. I think it's a resilience surge plan that we're looking at, given the lessons that we've learned via the pandemic and the fact that we need to surge and we need this resilience built in all year round, albeit that we may have to respond to different issues at different times. So yes, you are correct.
Thanks. It would seem to make sense, wouldn't it? Because particularly as we have surges in activity as well during the summer, don't we, here in North Wales? Okay, so we are noting the plan and the assurance that it's being developed and implemented to ensure management of the current and future pandemic and winter pressures. So thank you for that. We then move on to the next item, which is the integrated medium-term plan. Over to Chris.
Thank you, Lucy. So I will take the paper as read, but would like to just take a minute or two just to run through some points that aren't necessarily documented there. So our integrated medium-term plan, otherwise known as the IMTP, is progressing well, and you'll note from the paper that we're now working to a revised timeline from Welsh Government, which is for submission by the end of March. This is the first time that the Health Board has submitted an IMTP, and board members will have already seen and will continue to see that the plan is more integrated than the annual plans that you've previously received. The evolving plan was subject to a very helpful PPPH committee workshop last week, and it's going to be discussed in PFIG committee workshop this week coming. The current position is that we have a long list of developments for next year, and they have had integrated scrutiny regarding their resource requirements. So that's specifically workforce as well as the financial resource. It'll now be further refined to make sure that those that we include in the final set of proposed developments fit firmly within the resources that are available to us, and we're very clear about that. I'm pleased to say that that list is closely aligned with ministerial priorities and our health board population needs. It also gives us the opportunity of having a reserve list of developments that we could commence in year should circumstances change and make that possible. And that has been an omission in previous years, and I think is a very useful addition. Last thing before any questions then is just to say that we as an exec team are clear that we are still very firmly on track to deliver that plan to you in an approvable form, and I think comes to board on the 10th of March.
Thank you for that, Chris. I can't see any hands up at the moment. I mean, as you say, and just to be clear, the revised timetable for review and approval by the chair is on the basis that you know, the comments submitted by the relevant committees will be incorporated in the next iterations, along with a much better and clearer integration of both finance and workforce. And I know you are aware of that, Chris, and you're confident that that can be delivered. Is that correct? Yeah. Thank you. Linda.
I rhyw radda, Lucy, da chi newydd gofyn yng nghwestiwn i, ond dim ond i ategu, cafon ni drafodaeth adeiladol iawn yn pwyllgor PPH yn dechrau'r mis yma, ac fel oedd Chris yn awgrymu, wnaethon ni cael drafodaeth, dwi'n meddwl, oedd yn symud pethau ni blaen, ond dwi yn meddwl bod yn bwysig hefyd tynnu sylw'r bwrdd at y gwaith sydd angen i'w wneud mewn amserlen dyn iawn. Oedden ni'n gwerthfawrogi fel pwyllgor yr holl waith sydd wedi cael ei gwneud ac yn talu teyrnged i bawb sydd wedi bod yn cysylltiedig â fo. Ond dwi yn meddwl bod o'n werth o ran y pwyllgor tynnu sylw'r bwrdd i'r ffaith bod yr amserlen dal yn dyn, a fydd o'n bwysig, dwi'n meddwl, fel bwrdd i ni gyd drafod yr amserlen yma ar ran y gwaith sydd angen i'w cwblhau cyn bod ni gobeithio cyrraedd y lan ym mis Mawrth. Diolch yn fawr.
Chris, can you just respond, please?
Yes, absolutely. The timetable is very challenging. It generally is challenging each year. This year, for a whole raft of different reasons, probably makes it that bit more challenging besides. I think it's important to state that one of the reasons it is challenging this year is because of the depth in which we are committed to go into to make sure it is properly integrated. We're absolutely clear that we need to live within our means from a financial perspective, but an integrated plan isn't about financial integration, it's about integration of all of our resources, and in that respect, however good a particular piece of work might look like on a balance sheet, if we're not able to resource that from a workforce perspective, for example, it is still of little benefit. So we're really clear that we need to work through that. That means drawing in more people to contribute their expertise and scrutiny to that process, which then makes the time frame that little bit more challenging. But we, as an executive team, are content that we have the steps in place to do that. Already at the workshop last week, Linda and colleagues saw a greater level of integrated detail than was previously the case, but still a work in progress. We will continue through into PFIG workshop next week, where again we will see integration coming even more through, leading us then through towards that March timescale, where we will be absolutely clear that the resources required are deliverable and are within the resources made available to us.
Yeah. Thanks, Chris. Jo.
Thank you, Chair. Just to make the observations that We have a learning event scheduled for next month, which is an opportunity for us to reflect on how the process has proceeded this time and what improvements we need to put in place in order to meet the requirement to bring forward the planning process for future years. We already know in good indicative terms what our allocation will be for the next few years, and I've already discussed with Sue and Chris the desire to bring forward budget setting and planning priorities almost as soon as we've put this year's plan to bed in development terms, so that we can create an even more advanced process for future years. Great strides to take us from where we've been to where we are now. Thank you. And then there's another ask, which is to further bring processes earlier on in the financial year for future years. Thank you.
Okay, thanks for that. So we are receiving this report outline the progress towards developing the plan and the revised timeline for submission to Welsh Government, and of course the revised timeline for review internally as well. And you've provided us with a verbal update there. I'd just like to really support the idea of the reserve list as well. I think that's a very, very welcome development. So thank you very much for that. Hopefully it will provide us with opportunities in the future that was very much needed. Thanks everyone. We will now take a lunch break, so we will come back at 12:35. If everyone again could switch off your cameras and your microphones, please. Thank you. Enjoy your lunch.
issue we have now.
Streamed, got it.
I'm going to mute yourself as well.
Okay. Is everyone ready to commence again?
Yes.
Thank you. Okay, so we go to the next item, the committee assurance reports. I plan to take these as read, but if there's anything in particular that needs escalating or explaining or updating, I'll ask for the chair of each report to say so. So the first one is the chair's report for COVID cabinet for January, November to January. And there's nothing to bring to specific attention of the board. The next one is audit committee. Medwin.
Thanks, Chair. Yeah, as read, apart from the matters requiring escalation to the board, and there are two items. The first being that the committee endorsed the revised remuneration in terms of service committee terms, a reference for board approval. That was the first, and the most important in terms of the assurance that we were given, even though no assurance was applicable at the time of the report when it was presented to us at audit, is the findings pertaining the long-standing governance issues relating to YGC as identified by the internal audit. It was undertaken, the review was undertaken regarding management arrangements within Ysbyty Clwyd, ensuring for effective governance, stewardship, and so on, including corporate and financial governance arrangements. And although recognising there had been several management changes in the hospital team over the last year, with substantive appointments having been made, that said, the key matters arising from this report was a lack of effective oversight and monitoring of the implementation of actions to address quality governance review recommendations, the lack of effective governance arrangements in place with majority of reporting to secondary care bypassing hospital management team, and there are significant challenges to delivering the savings required for the site according to the key messages we had from this report. The audit committee was unanimous in escalating this to the board for their views and to take it forward from here. One of the other main concerns was that if this, in terms of effective governance arrangements and the sort of management arrangements here, were they unique to one site or were they shared on all three sites? Thanks.
Thank you for that, Medwin. Could I ask, please, for a response on this? Because as Medwin has indicated, you know, these have been long-standing concerns that have been raised by the QSE committee as well. I don't know if Nick or Jill want to respond to that, please. Jill.
If I may commence, I'm sure Nick will want to come in. I think there's two things I want to pick up. As part of the ongoing work around governance, this is something we need to pick up across the whole of the organisation. So we've accepted the report findings, but as part of the review of the organisational structures, this is very much part of our agenda to ensure that there's seamless escalation across. On top of that, both Nick and I have placed in the diaries some meetings with the senior management teams across the organisation to go through the learning from these reports so it can influence us going forward in terms of those structures. But you'll know, Lucy, this was very much part of our second wave of governance review.
Thank you for that, Jill. Nick.
Apologies, Chair, I wasn't able to hear the question due to some IT issues at this end.
Yes, we seem to be having gremlins in the system today. It was just the point of the matter that's been escalated to the board in relation to long-standing governance issues relating to YGC that's been identified by Internal Audit Wales. And I was just looking for an update, basically, and some assurance as to how this is being taken forward.
So thank you, Chair, and I agree with what Jill said. I did hear that part of it, her answer, and would reiterate the close working that she and I and colleagues are having with the senior leadership team within YGC, and indeed meetings exactly on this area planned in the next few days to continue that work at pace.
Thank you very much. So just picking that up then, Medwin, it will be followed through as well for QSE committee. And in fact, we discussed it, the need for an update against the quality governance issues at our last agenda setting meeting. So we should get an update at the next meeting on the 1st of March.
Thank you. I think one of the concerns in the meeting was that the change of management that had been a period of flux for over a period of time now, with several senior appointments being made over that time, and this was adding to the pressure. But with new regimes coming in, the problems still exist, and you know that was the issue that came out in audit. And was it common on the other sites in addition to this one site that we're talking about? Those were the main issues.
Thanks, Madeleine.
I understand the actions taking place as a result of this audit report. Thanks.
I would just add, Medwin, that whilst we have made and did make a substantive appointment to the Director of Nursing on that site, and that is a critical part of the triumvirate. Unfortunately, she was involved in a road traffic accident, has been off for some time as a consequence of that, but she's just returned. So it is an opportune time to pick this up with the team. In terms of the stability of the other sites, there is a great degree of stability, as you know, within some of our other sites, and but clearly this is something shouldn't rely on solely on personnel. It should rely on our system. So twofold approach here. One of them is the one that Nick and I are taking forward, and the second thing is the golden thread of governance that we're working on across the board.
Thank you.
Thanks. Louise, did you want to say something?
All I was going to add was that, of course, the recommendations of that audit, although it didn't have an opinion, will still be monitored by the audit committee. So they will be tracked by that route in the usual way. It was just to remind board colleagues of that fact.
Thank you, Louise. And as I said before, it will be given further scrutiny again at QSE committee as well. Obviously not in relation to the recommendations of internal audit, because that falls within the audit committee. But we will pick up the wider quality governance issues again at QSE committee. That then brings us on to the Performance, Finance and Information Governance Committee. John.
Thanks, Lucy. In terms of escalation to other committees, I'm obviously taking the report as read. We were looking for workforce strategy to be taken to PPPH alongside the IMTP, which I think there's been we had then had a subsequent PPPH meeting, but Linda can comment on that further, I think. I think it's probably worth highlighting a number of risks that came out of the last meeting as well. Some real serious concerns of risk around the business case, governance and process. Issues around the IMTP process as well, I think, in terms of risks from a feeling that we haven't got the assurance yet in terms of the integrated nature from a financial and workforce point of view. There are some long-term concerns around the restriction in capital available to us, which might restrict what we can do in the next few years. Concerns around savings delivery, particularly with regard to recurrent savings. And whilst we'll probably, the indications are we'll meet our targets this financial year, if we can't get that balance of the recurrent, more emphasis on the recurrent savings during the IMTP period, it might actually impact on what we're trying to do. And I think there's some overall concerns as a general principle, our performance with the performance measures nearly all showing a sort of a negative trajectory over a period of time, which is of concern.
Thank you, John. Any questions in relation to that? No, thank you. So that brings us on to the Mental Health and Capacity Compliance Committee. There are 2 Chair's Assurance reports here covering the last 2 meetings. And the first one, we recommended approval of the revised terms of reference to the board. The terms of reference are in the meeting papers. Can I first ask that is everyone content to approve the revised terms of reference?
Yes.
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 Thank you very much. The second Chair's Assurance report then, we have no specific matters requiring escalation to the board, but I would want to just note the ongoing risks regarding the recruitment of Section 12(2) doctors, the risk register and the ligature risks were highlighted as well as an area to be addressed, along with the risk of age-appropriate support relating to children when they're being admitted onto an acute adult mental health facility. That's a discussion that is also being had with the Together for Mental Health Partnership Board. We're trying to engage with our partners on that as well, and particularly we've been doing some deep dive activity and discussions relating to the use of Section 136 suites and the activity around with our partners for the Criminal Justice Liaison Service and the North Wales Police, particularly when we are seeing an increase of young people actually being presented to our Section 136 suite. So there's work ongoing around that. John.
Thanks, Lucy. It's only a very minor one in terms of both meetings can't be both inaugural.
That's how it felt though, John. But yes, okay. You are absolutely correct. They can't both be inaugural. And we note that correction. Thank you very much. Okay, that brings us then on to the Remuneration and Terms of Service Committee, which I present on behalf of the Chair. Again, taken as read, there are no specific issues to be referred or matters escalating to the board. Are there any other comments or queries? Is that an old hand, John?
Yes, sorry.
No problem. Thank you. So Partnerships, People and Population Health Committee, known very fondly now as the 3PH Committee. Over to you, Linda.
Diolch yn fawr iawn, Cadeirydd. Roedd un cyfarfod fel arfer llawn a llawn drafodaeth. Y ddau eitem sydd angen tynnu sylw'r bwrdd ydy un bod Pwyllgor wedi cynnig gwelliant ar y cylch gorchwil ac felly hwyrach bydd angen i'r bwrdd cymeradwyo, a mae'r cylch gorchwil estynedig wedi mynd i'r Pwyllgor archwilio, ond o ran y bwrdd, hwnna ydy'r tro cyntaf i'r bwrdd gweld y fersiwn diwygiedig, felly mae un eitem yn fanna, ac yr llall oedden ni'n croesawu'n fawr iawn fel Pwyllgor, cyfle i drafod yr adroddiad ar y gwasanaeth i gefnogi llesiant staff gyda'r acronym SWS. Wrach bod hwnna'n reit addas yn y Gymraeg, be bynnag. Ac oedden ni'n croesawu hyn fel Pwyllgor, a diolch i Pwyllgor Piffig am gynnig i ni drafod yr adroddiad. Mae'r gwasanaeth yn rhan o strategaeth mwy eang yn ymwneud â llesiant staff, ond oedden ni eisiau tynnu sylw'r bwrdd at y gwasanaeth ac at y ffaith hwyrach dyle ni fel Pwyllgor gadael y bwrdd wybod pryd da ni'n cael diweddariadau oddi wrth y gwasanaeth. Bydd hi mor bwysig i sicrhau llesiant y staff fel da ni'n symud ymlaen. Mae yna gymaint o bwysau wedi bod arno nhw dros y 2 blynedd dwytha. Ac fel Pwyllgor, da ni wedi ymrwymo i trafod llesiant staff yn aml yn ein trafodaethau Pwyllgor. So dyna'r ddau beth oedden ni eisiau tynnu sylw'r bwrdd, ond hapus iawn, of gwrs, i ateb cwestiynau ar unrhyw eitem arall yn yr adroddiad. Diolch, Lucy.
Thank you. Any comments or questions? And I just note the comments there about the IMTP as well, which I know we have just had a discussion about that, but I've noticed your reference to concerns about the timeline for that and relevant scrutiny. Okay, so moving then on to the stakeholder reference group. Is Claire with us? I can't see her. No, I think Claire's had to leave us now, hasn't she? Are there any, I'm hoping there aren't any queries then, because I don't think we've got anyone to answer them. So we will note that report, and there's nothing specific to be escalated. So we then go on to the Healthcare Professionals Forum. Gareth.
Thank you, Chair. There's nothing I would say is escalation, but there are a couple of pieces of advice that the forum have come up with, which I would like to highlight to the board, if that's okay. They both relate to an agenda item we had around the transformation and improvement work that's going on. We had a very good presentation from Chris's team on the topic, and the forum was particularly engaged, I think, in this topic. Found it to be a very interesting topic for them to discuss, and they absolutely support the view and the plan that we should have a single approach to T&I, as it's called occasionally, across the health board. I think as part of the enthusiasm of the discussion, they were very keen, the forum members, for them and their constituents really to get involved in the work. And whilst we recognise the work is at an early stage, we felt there was value in trying to get the clinical voice into this programme as soon as possible in terms of developing the foundations and an approach going forward. So we advised that perhaps a communication and engagement plan be developed to address this. And I'm pleased to say that Chris's team accepted that, and I believe we'll be looking at how that may be created. The other bit of advice we gave was the forum also supported the idea of the focus of perhaps doing fewer things but better as an approach, as a way of being more successful around our T&I agenda. But it was also concerned about the prioritisation framework that would need to underpin that in terms of, you know, what our priorities are, what we are going to throw our weight and resources behind. I think it was concerned to ensure that there was a validation of that framework and that approach, really to ensure reliability and inclusivity, and that you know, we're trying to mitigate against sometimes the unconscious bias that can creep into these decision-making processes. Thank you.
Thanks, Gareth. Okay, so we move then on to the stakeholder the local partnership forum. Sue.
Hi, Chair. Gremlins as well. I don't think there's anything to escalate specifically to the board. I think we've had some good conversations. We've got a further meeting. Clearly, what a focus of conversation will be the impact of the operating model. Not sure my camera's working. Make it there. So a key focus will be on operating model and the delivery of the operating model over the coming months.
Thank you, Sue. We then go on to the targeted intervention improvement framework. Jill.
Thank you, Lucy. No, I don't think I've got anything to add to that, and we had the previous agenda item, so thank you.
Thank you for that. So then we move on to the next agenda item, which is the quality and performance report. Sue, please could you take the report as read, but highlight anything in particular? Thank you.
Yes, thanks, Lucy. So I'd just like to talk a little bit about the content of the report. So we now include a summary dashboard on pages 3 to 4 and an executive summary on pages 6 to 7, which just gives some highlights. I think the main points I'd want to highlight are just around the impact of the COVID pandemic on the performance, particularly around planned care. Obviously, we've had to pause a lot of the planned care activity this year, and that is affecting some of the metrics that we're reflecting on the charts. I think, Chair, you helpfully highlighted that there was a colour coding error on page 28, which around second and third metrics around CAMS. So I apologise for that mistake, and we have put in place a further validation check going forward around that. I think apart from there have been 2 NAVA events that we need to highlight, in which are shown on page 36 of the report. That is the only thing that I'd be really highlighting, but I'm happy to take any questions. Thank you, Chair.
Thank you. Are there any comments or questions on this? So I think we need to note that this particular report was not accepted at the QSE committee meeting on the 11th of January because of a number of concerns that I had about some of the, well, firstly, the accuracy of some of the information contained within the report, some of the indicators and the narrative as well. That included what you've just referred to, Sue, in relation to the indicators on, specifically actually on CAMS, which is on page 28. And I did highlight before QSE committee to you that these were, I was querying the performance arrows. It's not helpful, and I know we are reviewing this report, and we've talked about the fact that actually these arrows will probably go because they're not actually helpful. Whilst recognising the manual element of this report, and that's the reason why we have errors like this. What I'm particularly disappointed about is that I did give you the opportunity to address these errors before QSE committee. So even though that was only 2 weeks ago, they've come before board again with the same errors in there. And one of the things I want to particularly point out as well, because I think is actually we have a narrative in relation to the psychological therapy waiting times. And the narratives are normally there by exception to provide the service with an opportunity to explain what the issues are in relation to performance, why the performance, what they're doing to mitigate that, and what the action and timescales are. And the disappointing thing about this is the fact that we've then got a narrative in relation to this indicator. It gives the wrong impression that actually there's a problem, and there isn't. They're actually overperforming. So I just want to make clear for the record that actually the measure of the percentage of adults waiting less than 26 weeks to start psychological therapy, contrary to the impression that the report gives, is actually doing quite well. We're well over target, and they've actually put a huge amount of work in the last 12 months to try and address the poor performance that was previously being reported. We've got to get better with these reports. This is public facing, and we need to give people confidence in the data that we're presenting to them so that they have a clear picture of how the organisation is performing. John.
Thanks, Lucy. It's a slightly more general point, but Sue referenced the never events. And I suppose my reflection is that it feels that we are seeing more never events than we used to if we go back 2 or 3 years. And I'm not sure I feel fully sighted on the number that we're having and what the causes are and what we're trying to do to address them, because by their nature, they should never occur. Is the scale greater in terms of the number of them, and how are we going to address that?
Thanks, John. And this is actually another good point, because the arrow is green and indicating going down. And whereas actually the never events are going up. So over a trend period of time. But in relation to that specific point, I'll bring Jill and then Nick in. Jill.
So in terms of the point that you made about not being cited, we are working on a report to go through Public Right Board in terms of ensuring that there is transparency. Lucy is aware that we do take these through QSE and our patient safety group. The other point I'd like to make is that we are currently doing quite a significant, I'm sure that's where Nick wants to come in, significant amount of work around a cluster of never events related to the WHO checklist and wrong site interventions. So there is a piece of work going on there. The third point is that in terms of that cluster and the never events, has been a conversation, and it will be discussed at the next risk management group about the escalation of the never events onto the risk register. I think Nick might want to come in to pick up the work that I know he's leading regarding WHO.
Thanks, Jill. Nick.
Thank you, Lucy. Thank you, Jill. Indeed, around that cluster of never events, there are some common themes around approaches, behaviours, human factors type approaches, because many of these were completely avoidable if only we had been following the procedures which should have been in place. So working to bring in external partners to really help us take forward some of the cultural issues, some of the approach issues, and to make this live for our teams. The good news in that, I suppose, is that some of the learning is actually relatively easily actionable, and it's just helping the teams to do that on a day-to-day basis.
All right, thanks, Nick. Jill.
Okay, thank you. Richard was next.
Thank you, Lucy. My question was also on the never events. I'm looking at the data in the report. They are a bit concerning. I was wondering if there was a standardised definition of a never event across NHS organisations generally, and how our profile compares with other places, and whether there are any lessons that can be learned from other places in terms of putting any issues right. I'm slightly made to feel a bit better by Nick's comment that they are, in many cases, they have relatively easy solutions to them. But I just wondered, given our profile, how it compared with other places. Okay.
Thanks, Richard. Jill, and then Nick.
Nick may have the benchmarking information. I don't have it to hand. What I will say is that, yes, there is a nationally agreed definition of what a never event is, which we do adhere to. In terms of learning from best practice, absolutely, that is part of the work that Nick's doing, for example, regarding the WHO checklist. And we know that one of our senior teams have visited another organisation where they are doing some really good work on WHO checklist and wrong site intervention. So yes is the answer in terms of definitions and what we're doing around best practice, and we do that across the whole of the UK, not just Wales.
Thanks, Nick.
Absolutely. So yes, there is a standard definition, and I'm afraid we don't benchmark well, certainly over the last 12 months with other health boards in Wales. That said, these are relatively small numbers, and I think we have to be quite careful about drawing too many conclusions around benchmarking with those very small numbers. I think it's also worth noting that some of the patients involved in never events have come to no harm at all, and the definition, from the definition, I'd suggest that you shouldn't take that these are necessarily catastrophic major harm events, although some tragically are. And there are other events which are every bit as catastrophic, if not more so, for patients in terms of distress and harm caused. So it's more a never event in terms of our process and our procedures and things that we should be doing as part of our day-to-day practice, rather than necessarily taken as a degree of harm.
I was just wondering then, as a result of those answers, is there any particular reason why our profile is worse than other places in terms of deterioration?
In terms of the why, Richard, I can't answer that question, but there is certainly a theme around us doing some of the really basic things in terms of simple checklists, making sure that teams are aligned before procedures taking place, ensuring that the checking, the paperwork that should avoid some of these things happening. So it is the day-to-day simple things that at times we are overlooking. Whether that's because we have a very tired workforce at the moment, I don't know. This is part of the work that we're doing with the human factors, is to understand why we're not doing some of those basic things, which makes such difference to the quality of care for our patients.
Okay, Lucy.
Just to build on that, the why question is a question that we've asked a lot and discussed a lot at QSE committee. And the need to ask that why in order to identify what's happened so that we can address it again. You know, QSE committee, we've discussed the fact that there needs to be an improvement in relation to how these incidents are investigated, because if we don't ask that why question, we'll never get the right solution. And that's the reason why, as Nick referred to there, that there's more work now being done from a human factors element, because I don't think that the human factors element has been sufficiently considered in the past, which is, Jill and I have discussed this, which is partly, we think, the reason why these never events are recurring, because we're just not asked, the service isn't asking that why question in the right way to be able to put the right controls in place to prevent a recurrence. So that's a piece of work that we are focusing on, and we've actually got another deep dive on never events at the March QSE committee. Jill, did you want to add anything to that?
I think you've covered it very nicely. I think the issue about the transparency is very important. I would reinforce as well, though, the point that that Nick made, that whilst we do absolutely focus on the never events, there are others that don't meet the criterion of a never event that may have caused significant harm. So we are giving those exactly the same scrutiny, and we do have executive-led reviews of those within 24-48 hours of that event taking place.
Thank you. Lynn.
Thank you, Lucy. I'd like to talk about stroke care, which has been on our agenda for several years now. I'm concerned that although there's a number of sheets dealing with stroke care and dealing with performance and mitigation and risks, are the risks proportionate into the care that we're delivering right now? I'm just concerned that even with all what's going on right now with the COVID pressures, do we need to do more for stroke care when it comes in as unscheduled care?
Jill?
Thank you. Lynn, we absolutely need to focus more on what improvements we can make in stroke care. And unfortunately, you'll have picked up as part of the board actions. I did have a meeting with the team arranged previously, which had to be cancelled, has been rescheduled for precisely the reasons you outlined.
So I understand that. I'm still concerned, though, about the number of people coming through, you know, with the displaying stroke symptoms. Do you think that meeting should be escalated a little bit quicker? Where do you feel that this fits into with our priorities?
So in terms of the escalation of the meeting, Lynn, I have got that in as quickly as I can possibly support it. I think it is an urgent conversation. That doesn't mean work hasn't been going on. We're not just waiting for the meeting. Okay. What I want to do is join up and see what we can do to facilitate. One thing we have been doing, Lynn, despite all the emergency pressures that we've had across the health board, we have been consistently ensuring that a stroke bed is available for an acute stroke arrival through the ED department. And we've been maintaining that throughout the pandemic.
Okay, thank you. So the update on these.
I'm just calling off my mobile because I'm trying to keep the because I'm trying to test the stream to see. Otherwise, it'll.
I'm sorry. Is that Rodri's? Could you?
No, that's right. So the call would be.
Could you put it on mute?
No, that's right, because the call would come through on the stream. Then I think they've got me muted.
Thank you. Sorry, Lynn.
So when you look at the stroke care on page 18, there's an awful lot of actions to take place. So are they being reported to PFIG?
I can discuss outside with Sue and John how they want to monitor them through PFIG. Happy to do so.
Thank you.
Okay, thank you, everyone. So we'll move on then to the next item on the agenda, which is the finance report, which we're being asked to note. Can we take it as read? Because we are a little bit behind, but I will hand over to Sue.
Thank you, Chair. So I think the only points to note in the report really are around the forecast. So we are now showing a balanced position in month, year to date, and for the forecast for the year end. That we sent an accountable officer letter to Welsh Government, which was around returning about 10 million of COVID specific funding. That's just because of the changes in the forecast around spend for that. So that doesn't impact on the forecast for the year end. Obviously, this really good performance, is in light of the additional recurrent funding from non-recurrent funding from Welsh Government. So we have got 82 million from Welsh Government, 40 million of which is supporting the deficit. And the only other point that I would note is that we have now achieved our savings target for the year. So we're above that 17 million target, but only 8.7 million of it is recurrent. And I'm happy to take any questions. Thank you, Chair.
Thank you, Sue. And going to bring Richard in.
Thank you. I was wondering if I could ask a question about the section in your report that is entitled Financial Position. It's on page 2. You've got a very interesting table in there, actual position, plan position, variance, which is just a swathe of zeros. And as long as I can remember, going back through the months, that table has always been a swathe of zeros. Given that that is the case, I mean, do you think, what sort of message do you think this table sends to the man in the street? And is it part of a, do you think it adds significantly to the sum total of human knowledge as far as the man in the street in Llangefni is concerned?
Sue? Sue, you're on mute.
Apologies, I did turn it off, but it didn't. So I guess, Richard, the answer to the question is it doesn't really give any information that is going to inform a member of the public. I think the other tables do, though, because we try and talk through the different elements of the financial performance of the health board. So we talk about savings programme, the income that we get from Welsh Government and how we're utilising it. We talk about the impact of COVID. I think if that slide is not helpful, then we can obviously talk about changing it. But we have moved the finance report on quite considerably over the last couple of years, and there's always room for improvement.
I'm sure you have, and I welcome your willingness to continually seek positive developments in it. But it's just that I've never ever seen anything other than zeros in it, and I think it's potentially misleading. So all I would ask is that you give some thought to that as to whether it's adding anything to your message.
Okay, thank you.
Thank you, Lucy.
Thanks. I do think Richard's made a good point there, because I know why it's to show us that the position is break even, but it looks like to a layperson that we've not spent anything, we've not received anything. So it's just looking at that appearance. John.
I'm happy to discuss with Sue in terms of maybe an update to the report coming to PFIG. I think historically, though, the numbers that would have been in a table like that would not have been zero prior to getting the strategic support from Welsh Government. And I think that's the difference here. We're in a position that historically we've not been in, where we can report zeros. It's a matter of how do we strike that balance of we are hitting our target of a balanced outcome compared to an overspend, and reporting that in a way that's meaningful. But I'm happy to feed that into any discussions with Sue in terms of improving the report.
Thank you. Are there any other questions then? John?
Yeah, the question's in relation to within the report around the 10.2 going back to Welsh Government. Can I just see clarity that the funding that's come in for COVID is a specific in-year funding, and the fact that we're actually giving 10.2 back in this financial year, what will be the potential funding from Welsh Government to continue with the COVID work in the new financial year? Are we actually running risk by giving money back in this financial year and not having sufficient in the next financial year to carry on some of the work that we know needs carrying on? Thanks.
Thank you, John. So the allocation that we get from Welsh Government is on an annual basis, and there is no opportunity to carry money over into future years. As you can imagine, the activity that we're seeing and the impact that's having on our cost base from COVID fluctuates based on the number of cases, and that's why we're in a position to return money to Welsh Government. In terms of the allocation for next year, we'll be going through that in some detail at the board workshop in February, but effectively they have given clear funding streams for the main programmes. That would be TTP, vaccination, and some elements of long COVID. And the expectation is that the cost of COVID within the network is starting to become a business as usual cost. So there is some risk around that, which we are quantifying as part of the budget setting for next year.
Thanks for that. I look forward to the workshop then, because I think it's a significant risk that funding returned this year and we're not getting sufficient next year. So thanks for that explanation.
Thank you. Linda?
Ga I just codi cwestiwn yn ymwneud â ynni, a risg o y codiad yn pris ynni sydd cael ei gynnwys yn eich adroddiad. I'd like to just raise a question around energy prices, which you do include in your report, and you have already outlined that the financial statement includes an additional allowance. But can I ask perhaps that when the forthcoming asset management strategy comes to PPPH, that perhaps there could be a specific reference to how the board is going to tackle the risk of increasing energy prices within that, so that we are better sighted as to what the strategy will be if, as anticipated, these energy prices will stay high for a while, and clearly they will be an additional financial cost for us. Yeah.
Thank you, Linda. So in terms of the fluctuations around the energy price, obviously that is something that is affecting the whole of NHS Wales, and our procurement colleagues are working sort of on a national basis to try and get us leverage to get the best deal around the energy price. That number hasn't crystallised yet, but I guess indications based on our energy bill is it could be up to 10 million. We are still waiting for those numbers to flow through, and obviously, we will share that as soon as we know it, and it will be part of the asset management strategy. It fits with the decarbonisation programme and thinking about greener energy. It's all around, how we sort of flex the estate going forward to be more efficient around our use of energy.
Okay, yeah.
Thank you. I'll bring Richard back in.
Thank you, Lucy. 2 questions. First of all, leading on from Linda's question, when we do an analysis of energy consumption, can we also include in it any plans we have underway or proposals for the future to enhance and maximise our energy efficiency? I'm thinking obvious things like water leakage, solar panels, that sort of thing. Because they would clearly help in getting the expenditure under control. So that one leads on from Linda's point. My other main question, though, is relating to the table of pay costs expenditure, which is on page 9, the one that sets out the rolling monthly performance. Looking at the line that relates to pay costs for primary care, the percentage variance seems to be fairly significant. It's 1.4 million, but that's on a budget of 14. I was wondering if you could shed some light as to what the reason is for that variance when other budgets, for the most part, seem to be in a favourable variance.
Thank you, Richard. Thank you, Chair. I think a large proportion of the adverse variance relates to the proportion of locum workers that we have. Therefore, the cost of the individual is greater than the budget. I'm not sure if that will cover all of that variance, but I will find out for you for the next meeting.
Do locums significantly adversely affect primary care as opposed to other sectors of our operations? Just wonder why that one would be in the red, but the others are in the green for the most part.
Yeah, so it also affects medical and dental, which is also in the red.
Okay, and thank you for that. And my query about the efficiencies on energy costs.
Yeah, so we'll pick that up as part of the strategic asset management, and when we pull that in as part of the budget for next year.
Okay, thank you, Sue. Lucy.
Thanks. I think Sue and Chris would like to address the comments there about the agency and primary care. Thanks.
I think so Sue kind of hit the nail on the head, and no doubt Chris is going to talk about this as well. I think there's something that we should hold in our minds when we consider the Primary Care Academy business case. We talked about the sustainability of primary care for a number of years. The Health Board, we're doing a lot to try and reinforce the sustainability of primary care, particularly as we try to move more services out of a hospital setting where they should rightly be delivered. It was just suggesting that we hold that comment and the facts in our minds as we consider the Primary Care Academy business case. There is a disproportionate impact in our primary care settings for a range of, not least of which the numbers of gaps and the immediacy of those gaps needing to be covered. So, but no doubt Chris will be able to elaborate more on the detail.
Thanks.
Thank you, Sue. It was that exact point. I'm sure the differential between locums and substantive post holders in secondary care and primary care are broadly similar, something like 50% on top as a rough figure in primary care. But I think the use of locums at the moment in primary care is significantly greater than it is in secondary care, and huge parts of primary care would not be able to deliver a service without the degree of use. And I think that's why it has a greater prominence in the financial breakdown.
Thank you.
I think it's fair to say that the locums in the primary care workforce, many of them are there as a choice of that's how they want to work, isn't it? Rather than they're not just between jobs. Some of them actually deliberately choose to be a locum because of the level of flexibility that it gives them.
Indeed.
Thank you. Okay, so we will move on then from that. So we've asked to note the report, which is provided for assurance. Now move on to vascular services, and over to Nick.
Thank you, Chair. So I'm sure board members will have read the paper, and if I may, I just very quickly like to highlight 3 potential areas, but of course happy to take any questions. Firstly, I'm sure members would have noted the concerning mortality rate coming out of the National Vascular Registry, and that's a national audit that's hosted by the Royal College of Surgeons. I think I'd also like to acknowledge the distress of families related to these cases. I personally always feel slightly uncomfortable when we talk about percentages and rates, because behind those numbers are real people with families who've lost their loved ones, and all the tragedy and hurt that entails. The audit shows our health board as a significant outlier. Indeed, the worst figures in the UK for mortality following major amputation. It's quite a complex statistical formula, and it looks at the 3-year rolling average mortality after major amputation. And you'll have seen that in the 3 years to 2019, we had a mortality of 15.9%. And although this is now reduced to 10.6% for the 3 years to 2020, this still remains the worst in the UK, where the average 3-year rate is only 6.1%. It's reassuring, but I'm reluctant to take assurance from the fact that our accrued mortality for 2020 for this group of patients was 3.3%, because looking at the reasons for some of these high rates, some of it does, I'm sure, relate to some learning opportunity for us in dealing with patients better in terms of case selection and care of those patients. But there's also a significant data issue in terms of us submitting data which doesn't provide full and accurate information. So we are doing and will continue to do work to understand what that data should be telling us, and to provide absolute assurance that going forward we're only providing the correct data to the national audit. Members will also have seen that we're doing some further data work with an external body, CHKS, in order to look at our major vascular outcomes going back 7 years, in order to really help us understand what changes in outcomes there may or may not have been since the centralisation of services in 2019. That work is proving more difficult than we'd anticipated. We had initially hoped that it would report at the end of January. I suspect it's now more likely to be the middle of February. So that was the first point I wanted to highlight. Secondly, if I may, Chair, just very briefly, I'd like to recognise the successful recruitment of a new vascular surgeon who's now in place. And we welcome new bloods to the team, and continually looking to support that team, and indeed have appointed some extra managerial and leadership support for the team also over the last few days. And lastly, before taking any questions, I just wish to draw board members' attention to the importance of the second stage of the Royal College of Surgeons report. And I'd expect to be in a position to bring an initial response from that report to the next board meeting. So, Chair, happy to take any questions, and I hope that provides a useful teasing out of some of the key issues.
Thanks very much for that, Nick. So I will go to John Cunliffe first.
Thanks, Lucy. For some reason, I could not get it off mute. Thanks for that, Nick. I think you've touched on the area that I was just had some questions about or wanted clarification on around the amputations, and I absolutely take your point about percentages are not quite the right way to refer to this at times, given that this is that people who've had a significant impact. But I think the first two questions was, you've referenced the 3-year rolling average, but then you quote in the 3.3% for 2020 for ourselves. But have we got a UK number for 2020 to compare that to? And then the second question is in the next paragraph down on page 2, you talk about the anticipated out of hours amputations that are exceptional events. But have you got a number or a sense of scale of what is exceptional? How many did we have in the last 12 months? Or what was the percentage of the total amputations, to give us an idea of, what is the occurrence of an exceptional event?
No, thanks, John. So no, there isn't a nationally validated number for 2020. We have done some work with peer reviews, similar networks, one similar network in the Northwest, which provides a very similar figure. But again, because of our data quality issues, I'm very reluctant to take either too much assurance from that, because I don't know the quality of the data that we've been submitting. So that comes with a very clear caveat. In terms of the detail around those exceptional cases, again, doing a lot of work to really understand that. And I think too early to draw any conclusions. But you're right to ask, and we will come back with that answer, John.
All right. Thanks, Nick.
Thank you. Lynn?
Thank you. Thank you. Nick, you mentioned about the CHKS review taking place, and from what I picked up, you said that we'd be clear then over the last few years as what our actual outputs and performance has been, which I look forward to seeing. However, I am a little bit concerned when you say that our data, you don't have 100% assurance that the data is correct. So how does that flow into the CHKS report and review?
No, thanks, Lynn. And this is absolutely key. And we have to be really careful, don't we, as a board, not to to draw conclusions from data unless we're sure that that data is right. I think in terms of the National Vascular Registry submissions, what was happening is that we weren't always making sure that we're including the correct patients. We weren't recording all of the cases accurately. And for instance, we weren't always recording what other illnesses they had, which plays into an analysis of the data. In terms of the CHKS report, unfortunately, at times, much less of a problem recently, but more significant going back a few years, a lot of the data just was not recorded and coded in the correct way. Therefore, the reason that the work is proving a lot more complicated than anticipated, and because we're looking for proxy markers. So if we didn't, for instance, record a patient who was being cared for prior to amputation, then we're looking at patients who might have been on that ward, and although it may have to be coded as having an amputation in the correct way, we might be able to identify those patients through recognising the ward that they were in and other treatments that they received. You can appreciate that's quite a large piece of work, and we're really grateful to have an external partner but to help us with it, but also when we do come back with that to board, to provide some external validation so we can all be assured that that's giving us a true picture.
Thank you.
Thanks very much, Nick. And as you have stated in the report, this is being reviewed. We're getting regular updates at QSE committee in relation to the improvement group work, and also progress against the recommendations from the Royal College report too. I just wanted to clarify, taking into account what you said about the data quality, the comment about non-vascular amputations, which are performed by orthopaedic teams, which should not be part of the National Vascular Register. Do you know, I think I know the answer, but do you know at this point whether any of the amputations undertaken by the orthopaedic team may have been included within the returns?
So I can tell you, Lucy, that we did include some patients within the audit that should not have been included. So therefore, that may have caused an inadvertent over-representation of mortality within this group of patients. However, until we've done the full analysis, I'm not assured that it may yet be possible that there were other patients that we didn't include that we should have included. So I'm afraid, Lucy, too early to say what the full ramifications and understanding from that is.
Thank you, Nick. And I know you are putting a lot of emphasis now on trying to get that assurance for the board, which is obviously going to be essential to our members of the public. They'll undoubtedly be alarmed by these figures. It's absolutely essential that we get to the bottom of exactly what's going on either way, and make sure that we've got appropriate actions in place. And we've discussed in detail at QSE your commitment to addressing these problems. John. John Galanders.
Okay, I'll go first on that one. Too many Johns. Thanks, Nick, for the report. I just want to pick up on the recruitment and the reference there to the consultants in post, which is obviously very welcome. Does that now mean that the team is actually fully upped to speed in terms of the full team vacancies, or are we actually still holding vacancies and still reliant on locum staff as part of the overall vascular service at the moment?
No, thank you, John. So at the consultant level, we are now at the full establishment, albeit you rightly recognise that there are some long-term locums. So there is still work to do for us in ensuring that we have a really stable and sustainable consultant workforce going forward. But consultants, of course, aren't the be-all and end-all of clinical teams, and we're also doing work to make sure that other grades of doctors and indeed specialist nurses and other staff members within that clinical team are at the levels that they should be, both in the central team but also in the spoke teams. And you could argue not part of the vascular work, but also really key, and there's a mention of it in the paper, is making sure that our diabetic foot pathways, our multidisciplinary diabetic foot teams are really at the levels that they need to be in order to assist patients at the earlier stages in the pathways. So progress, John, but certainly not where we need. We're not yet where we need to be in the longer term.
Thank you. John Cunliffe.
Thanks, Lucy. Nick, I was just following up or reacting to your early comments around the data quality issues, and I suppose what I haven't got is a sense of how far back these data quality issues go. Is this something there's been an issue for 6-7 years, or is it more recent? Do we have a sense of how badly we've been performing in terms of capturing data in an accurate way?
My sense, John, if you're asking for my sense, is that this is a very long-term issue. And I think it's both in terms of our recording of data initially, but also really crucially, our clinical ownership of that data before it's submitted. And we now have fairly robust processes in place to ensure that each consultant, so that their cases, before they're submitted to the registry, they're absolutely making sure that it's an accurate and full picture of that patient's care in order that we're clear going forward. So it is that recording of data, the validation of data, and a timely submission of data that we haven't been doing and we are now doing.
All right, thanks, Nick.
Okay, I can't see any more hands up. So thank you for that update, Nick. And we will, of course, be receiving a further update and hopefully more detail in relation to the actions taken at the 1st of March QSE committee. So we're asked to note that update from the Vascular Steering Group and to note the focus on quality, safety and patient experience on the decision-making timeline. And now we move on to the infection prevention and control mid-year update. So we have Rebecca here. So welcome, Rebecca, to the board.
Thank you.
And you're going to give us a presentation, and what is in the pack has the same content as the one that is being shown, I believe. So we have read the presentation, and I'm just really conscious of the time. But if I could just ask Jill to very quickly introduce you, and then we can go through. Thank you.
Thank you.
Jill.
Thank you, Chair. I recognise the time restrictions that we're under at the moment, but I would like to introduce Rebecca as our Senior Infection Prevention Control Advisor across the Health Board, and welcome her. She's only been with us a few months, but is having an impact. And before she goes into her presentation, I'd like to thank her and her team for all their support over the last months, as we've learned as we go around the mitigations that we need to put in place around this pandemic, and the support they've given across the Health Board, and I mean across the Health Board, primary, secondary and community care. But I won't, I'll ask her to introduce her slides. Thank you.
Am I okay to share my screen with the slides? Is that all right?
Yes, thank you.
Can you see those?
Yes, thank you.
Okay, excuse me. So yeah, I'm Rebecca Joad. I'm quite new to the Health Board, came in November, so bear with me. But I'm just going to do a quick tour of an update of things that have been happening. So the next slide is just the infection prevention updates that I'm going to go through, so I won't spend much time on those. So in terms of the team, we have a team that works across VCU, based in the 3 main sites. They work Monday to Friday, but there is an on-call service 9 to 5. And out of hours, there's additional service provided by the on-call microbiologist. There are current shortfalls within the team. Sorry, just put it onto a full screen. We do have some vacancies within the team, and we've had some sickness recently, but the sickness has improved and we are actively recruiting to the vacancies at the moment. But that does include 2 of our 3 CSLs and 3 Band 6s where we've still got vacancies. So there's more to be done there, really. We've put a risk assessment in regarding that, and I've been keeping the clinical teams informed in terms of what we provide. As I say, I joined the team quite recently. We're getting on advertising the vacancies, and the tissue viability team have been moved out to enable the IP team to focus really on IP and managed elsewhere. In terms of the future, learning from the pandemic, we're looking to build an IP team for the future, really, and we're putting together a business case on that. So the key risks we have in the last couple of months just stood down, or the last month really, the Safe Clean Care meetings, but the work streams are continuing and the philosophy continues. There are 2 main IP risks that are on the board assurance framework, one related to COVID and one hospital-acquired infection. But in comparison with other Welsh boards, we're not an outlier for the 6 microorganisms that are mandated to record. And our position is actually 2nd, 3rd or 4th when you look at the data, which I've got on the next slide. You're probably familiar with the way this is formatted. I'm pleased to say that our position on C. diff in December from 4th to 3rd, and our position for Pseudomonas also recently. This shows the individual trajectories versus the actual numbers of infections. And again, in some of those cases, we're seeing a less steep rise in the recent months. We have had 10 MRSA bacteremias, giving us a rate of 1.7 per 100,000. But we are 3rd compared to other health boards, and we're doing a full PIR on each of those cases to see if we can identify any learning. There was a new Welsh Health Circular issued in September with improved goals looking to lower the burden of infection, and VCU were on target for some of those goals around antimicrobial usage and around the E. coli bacteremias, but others are more challenging. The C. diff one getting down to 25 is going to be quite a significant challenge, I think, for all health boards, and we currently sit at 36, but as I say, our position within Wales is improved, which is good. We do full PIRs on our healthcare associated infections to identify any lapses in learning. And we're reviewing this process at the minute to see, to make sure that lessons learned are actually shared right across the health board. So in terms of COVID-19, it's obviously been dominating the work for 2 years now. And the guidance continues to be updated several times in recent months, but we keep on top of that and make sure that the changes are highlighted to the staff. We currently have a significant number of staff who have been off with COVID. That's reduced recently, and patient numbers appear to be coming down a bit as well, which is good news. Inpatient testing regimes have been enhanced. So we're now doing those every 48 hours where we've got outbreaks. And as I say, we're providing clear guidance to support sort of decision making to help the flow of patients. This graph just shows the weekly number of inpatients with confirmed COVID by health board. And higher, that was the week of the 9th of January, the last data that we had on that. In terms of outbreaks, you'll be aware that there was a significant level 3 in YG in spring last year, with 11 wards and 2 community hospitals affected. There's been reports written on this, and an external review was commissioned by the board, and all the learning addressed through a comprehensive action plan. I'm going to come back to some of those shortly in terms of changes that have been made. We've had other smaller outbreaks since then at YG, but contained much more quickly. But obviously the emergence of the more infectious Omicron variant in December has given us some new challenges. All 3 sites do have COVID outbreaks, but only one of them is now at level 2, the others are at level 1. Patients are generally asymptomatic, and we've seen spread within the bays before it's identified and we're able to move them. So the external review came back in September and actually highlighted several areas of good practice, which was great, and I won't dwell on those, but there was a number of areas that they were impressed with. They also looked for some improvements regarding signage, installation of new pods, installation of doors on patient bays, and to make sure we were clearly segregating patients on different pathways. An SOP to support staff with decision making on those pathways, and clearer guidance around staff rooms. But you can see from some of the pictures there that some of the changes that have been made more recently. And I'll come back to some of those afterwards. I'm not going to go through this in detail, but there's a significant amount of key learning from the outbreaks. So as I said, for each case of healthcare associated COVID, there is a detailed patient instant review completed, and that's scrutinised by a panel led by the Director of Nursing. A number of key themes have been identified over the course of the outbreaks, and a lot of actions put in place to prevent reoccurrence. So this is the key learning that we've seen from the beginning of the outbreaks. This isn't new, but it's just a summary, really. The Safe Clean Care Harm-Free programme has got 3 domains: safe place, safe space, and safe action. And we've used this programme to make those improvements from learning from COVID. So under safe place, you can see here just one of the examples. There's been an awful lot of work done on changing areas for clinical staff, and you can see the sort of before and after pictures, which has made a massive difference. These are taken from YG. Here on the pictures, you can see they've put doors on some of the bays where these didn't exist, and a lot of work has been done at City Gwynedd regarding this. So 4 wards have been done. There's 1 in progress, and there's 4 other wards I think that are under review requirements. They've also put bay doors in at Llandudno, additional hand wash basins, flooring at Colwyn Bay, and there's been a lot of work at ED, the emergency department in YGC, where they've formed 12 single rooms in majors and resus, and amended ventilation within those areas. Excuse me. So since I came to the health board, we've done another review of entrance and egress complete at the sites. So we've got appropriate signage and segregation as people enter our sites. Within the estates and facilities, quite a lot of developments, done ventilation reviews for all of the areas. Ventilation is poor in some of those areas and reliant on natural sources, but now we've got that full review, we can use that to help support decision making on ward allocation. The addendum to the clinical framework for cleaning has required additional cleaning staff. 96 whole-time equivalents are identified as being required. And there's just 25 of these outstanding, and they're working through the recruitment process now. We've reinforced the credits for cleaning auditing, and we're looking to establish a task force to agree proficiencies for a specific discharge cleaning team. In terms of the hydrogen peroxide is used as an enhanced cleaning after infections. It has been more difficult to do this enhanced cleaning because of the lack of decant facilities while areas have been escalated. Certainly more recently, the last couple of months has been more challenging, but there's been a pilot of a new product, hypochlorous acid, which is proving to be safer and less time consuming than HPV. So we're looking to establish a group to lead on the next steps and looking to roll that out. So in terms of safe space, an example from this is bringing the Liat point of care testing to all 3 emergency departments last summer. And this helps provide quick COVID results and enables patients to enter the correct pathway from ED. So we know where to put them straight away. We have the results and make that decision quickly. There's been a number of initiatives under the Safe Action Programme, which I won't go through, but we now have 132 infection prevention champions, which is really good news in all the areas. We want to get one on every shift ultimately. There's an awful lot of work going on with catheter-associated urinary tract infection and reducing infections there. We've got compulsory training now on donning and doffing for staff with videos. And we had the pilot to introduce lateral flow testing for visitors was rolled out in December, and also supports patients in mental health wards to return from leave safe. The Safe Clean Care section is on the intranet, and all the updated policies and procedures are now available. And we're working closely with partners to establish new resources, the new intranet pages as they become live. So moving on to decontamination, there are some points listed here in terms of issues that we're addressing. Again, I'm aware of the time, so I won't go through them all, but we're reviewing the risk registers to check all of the risks are included. And in terms of our assurances and achievements, we have a committee that monitors the situation and has an improvement programme in place. There's a capital replacement programme there for the age sterilising equipment. We've moved to doing decontamination audits now twice a year. It was once a year to ensure we get that compliance. The pictures there were from a recent visit to the emergency department in City Gwynedd, where the procedures and the practices were found to have been a really high standard. So there is some really good work up there, but there's going to be some more required decontamination. Antibiotics, appropriate use on the news again today. Still seeing some areas of inappropriate use and high levels of resistant organisms, particularly E. coli, but that's one area that we are making a difference within the organisation. We work with urinary catheters and our levels are below the tree. All acute sites have reached the improvement goal regarding antibiotic usage, which is great news. And we have all hospitals using the Start Smart and Focus audit tool. The microguide is available to all staff, regularly updated, and there was a very successful antibiotic awareness week held in November. So my final slide is just in terms of where we're heading. We're working towards zero tolerance. Well, we have a zero tolerance to healthcare associated infections, working towards reducing that, to make improvements with our review processes. As I say, learning from the pandemic to build an IP team for the future and increase our medical engagement to all levels within IP. Further improvements to be made to the estate, working with IT to develop systems to release time to care and provide us with the data for assurance. developing a full decontamination strategy and a planned programme there, and promoting the antimicrobial stewardship programme. Also want to work with universities to help develop some infection prevention programmes and help grow our own staff, and work with partners to support them with their programmes. So a bit of a whistle-stop tour, but thank you very much. Hope that's gave you some information.
Thank you for that, Rebecca. That was really helpful. Are you taking the presentation down now?
Yeah, sorry.
Thanks. So before I bring in specific questions, I can see, Joe, you've got your hand up. Do you want to come in now?
Yes, if I could. I just wanted to say how engaging I found the presentation and how useful it was to see the assorted pictures, a real example of where pictures most definitely tell 1,000 words. And I just wanted to say thank you very much. Thank you.
Thanks. Okay, I think John's hand went up. John Cunliffe's hand went up first. Thank you.
Thanks, Lucy. Thanks, Rebecca, and welcome. Couple of quick questions. One, I think, is on the comparison slide. I think it's page 5, particularly with reference to MRSA. What are Anair and Bevan or CUMTAF doing differently with regard to MRSA, and what can we learn from them? Because they seem to have a very significantly lower incidence than the rest of the health boards. And then the other one was around the COVID comparisons. And whilst we need to be looking at our comparisons of Wales, do we also need to be looking at comparisons with regard to the northwest of England as well? Because our modelling always seems to be more reflective of northwest, I think, historically in this pandemic than it has been with the rest of Wales.
Yes, I think we should look to other health boards to learn the lessons. So I came here in November, and as I came, COVID started to increase again, and it's been quite a difficult period for us. But I think that would be really useful moving forwards. We get the data, say, to compare ourselves with other health boards, but it would also, as you say, be useful moving forwards to get that northwest data, because I think that is also available online. So I'll look to do that for the future and put that in the annual report as well. Thank
you. Thanks, Rebecca. I think it was, well, let's go with John 2 next. John Galanders.
Okay, we'll start using numbers. It sounds better, doesn't it? Thanks, Rebecca. That was really good and very comprehensive in what you put forward. Just the one area, though, that I noticed didn't seem to reflect very highly there, and that is in terms of the implications of visitors and the impact on visitors potentially coming in, bringing infection in with themselves or visiting people and then going back out. So particularly during the height of the COVID and the lockdown, I was very aware in hospitals that we have where we had lockdown with no visitors, but actually there was no restriction on patients then actually going out to meet visitors outside of the hospital premises, going back in. And there's also examples of people like Deliveroo delivering food for patients standing outside hospital. So the question basically, I suppose, is what is it within your plans that you're doing to strengthen the need for visitors to be more aware of the role that they've got to play, and also patients, once they're actually admitted, to ensure that they're not going to be carrying infection outward or bringing infections back in again? Thanks.
Yeah, it's a really good point. It's a difficult situation, really, because if we don't have visitors, then that can be obviously very detrimental to people as well. We have introduced very successfully the lateral flow testing for all our visitors before they go to inpatient areas. We screen them. There's a series of questions that they're asked, and we also check their temperatures. Apologies, I've not got my video on. So that has worked out really well. There are leaflets for visitors, there's information on the website, and there's leaflets, and there's information for patients, but getting that balance is difficult to do. I think as COVID hopefully declines again, we need to review what we do, because we haven't also opened a lot of our cafe areas, etc. So footfall is still reduced, but we need to, when we start to open up those areas, need to do that as safely as possible. But it's an ongoing challenge, really, and balance of the risks for patients.
Could I just come back on that in terms of the testing that you're now doing, in terms of the times that are actually occurring? Is that actually occurring the whole time that visitors have access into wards, or are we actually operating a 9 to 5 type service? Again, I'm just conscious of what's happened in the past. There were restrictions in terms of when people were on the doors trying to encourage people to do hand sanitizing, etc. So it's just an assurance from yourself that it is being picked up on whenever business is open, then the testing is in place as well.
Yeah, the visiting, no matter when they arrive, it should be the same checks. So if they should provide evidence of a negative lateral flow, and if they haven't, we can do lateral flows when they arrive. So that shouldn't matter what time they turn up to the wards, it would be the same process.
Sorry to labour the point, Chair, but you said at the point of ward, so it could well be that somebody is entering into a hospital premises who is infectious, but actually doesn't get tested until they arrive at the ward point. So my point really is, what are we doing at the main entrances to capture any problems at the point of entry rather than at the point of entry to a ward? Thanks.
Okay, yeah, no, there are notices up in terms of advice for visitors. We will normally try at the 3 main sites to have somebody who greets the visitors and discusses, ask them to change their mask, to use the alcohol gel, to find out their purpose. So that should be there during working hours. Outside of standard working hours, that isn't always possible. And obviously there's more than one entrance to a hospital, so it is quite difficult to regulate. But the signage should hopefully help support that, what they should do and the procedures that we have.
Okay, thank you very much. Cheryl.
Thank you very much, Chair. Thanks for that, Rebecca. Very, very good report. I'm continuing. John has asked most of my questions around the hospital visiting part of it. I did visit YGC and unfortunately did not encounter any checks or anything. Went all the way through the hospital without being challenged at the invite of a ward, I have to say. But once that was escalated, it did change the next day. My first question is around the numbers of our cleaning staff. They do an amazing job. I was just wondering, have we any update on how many of them have been affected by COVID? Are we seeing a big dip in our cleaning staff because we're obviously only as good as they are? Just wondered if we had anything on that. That was the first bit. Thank you.
I'm happy to answer some of that with Rebecca's support, but in terms of the our cleaning staff, I completely agree with you, Cheryl. They are fundamental to our infection prevention campaign. We have been aware that they have been heavily impacted by sickness, certainly over the periods where we saw the high escalation of sickness, but we are working with colleagues to see what we can do to support those important personnel and what we can do to access additional domestic staff to be able to support them.
Thanks very much, Jill. That's reassuring to hear. And the last part of my question was HMP Berwyn, how much preventative work have we done in our healthcare facility there, and have we had any outbreaks there, please? I'd be very interested to know. I did ask it at the previous board meeting. Thank you.
Yes, there has been an outbreak at the prison. We have been actively involved. They've been holding weekly outbreak meetings, which are chaired by Public Health Wales, and the infection prevention team from Wrexham have been involved, providing advice and helping to monitor the new positive patients. I believe that is subsiding now. The numbers are reducing, but they had a number of staff and prisoners who had COVID. But there was a meeting, I think, yesterday, and the numbers are coming down, heading in the right direction. They brought in quite a few additional measures, because I think the guidance also increased nationally for prisons at the same time as well. But as I say, the situation is now improving in there.
Thank you very much for that update. I would find it helpful if that data was included in the rest of our general data, seeing as we provide this healthcare service there, and that would have been very handy to have known previously. So thank you very much for that, Rebecca.
Teresa.
It was just in response to Cheryl. Very aware that they've been updating their work on a health and wellbeing strategy within HMP Berwyn, which I think is great news. Of course, that all links to East area at the moment.
I think we've lost Teresa again. Okay, so can I ask Rebecca, can I ask what may seem like a really stupid and very basic question, please? But from a layperson's perspective, the number of infections across some areas, as you have presented to us, is going up, and there are various reasons behind that. But you know, a layperson might think, well, given the amount of PPE use that is now in place, the fact that all staff and visitors should be wearing face masks, the increase in hand cleaning, wouldn't you expect the infection rates to actually go down, not be going up? I'm sure there is a good reason for it, but I thought I had to ask.
I'm not sure there's a good or a quick reason. The pandemic has brought in some ways its own challenges, and in some ways has not really helped. So one example of that might be there's been an overuse of PPE. So some thought by some staff that, you know, they were wearing gloves to protect themselves, but then they were carrying out less hand hygiene. So there has been issues that have come along like that, and I think the focus has been very much on COVID. And perhaps less so on a number of the other organisms that have been causing us problems. But there's lots of different reasons really that go into it, outside of actual practice as well, in terms of the estate, the movement of patients that we've had to do. There's been a lot more movement, putting patients on the right pathways, moving them when they've become positive, etc. And none of that really helps with continuity of care. And also makes it difficult for the staff, and all the amount of staff sickness and shortages, etc., have also been a real challenge. But I think, you know, we have maintained those standards. I think, you know, from what I can see, the board has done very well, and we just need to keep building on the work that we've started and keep seeing those improvements.
Okay, thank you very much, Rebecca. So we've asked to receive the infection prevention update presentation from Assurance. Thank you for presenting to us, Rebecca, and we will now move on to the next item, which is the Primary and Community Care Academy business case. Conscious of the time, so we'll need to be really focused on the remaining agenda items. Thank you. Chris.
Thank you, Lucy. I'll be quick then. You have a substantial case in front of you. The Academy is one of our success stories in the Health Board, and through it we've been able to lead on a number of exemplars that demonstrate the breadth of primary care and have informed the primary care model nationally. Examples would be nurse consultants in primary care. We were the first in the UK to fully adopt that.
advanced practitioners in physio, audiology, OT, nursing. In fact, the OT, physio and audiology roles in primary care have attracted quite a lot of national, and in the case of the OTs, international interest. Paramedic partnership with WAST, and we were one of the early adopters for physician associates and finding a role for them in primary care. So lots of really good work, and others regularly look at us in those areas to see what we're doing. It has already actively contributed to our primary care workforce, both in terms of creating new roles, but also in terms of bringing in some people who were looking at us as being forward thinking in this area. But it doesn't go far enough, and we've already talked today about the demand for locums in primary care, which is likely to increase, and the need to build upon the academy is what informs this business case. It sets out our ambition to grow the work we've already done over the coming years so that we can move more people through. You'll see that there is an addendum in the pack. The addendum outlines an approach to demonstrating business realisation as the academy progresses, so that we can give assurance against the significant financial resource that's being required, and to avoid any doubt. A failure to demonstrate a satisfactory return on investment would see us cessating those areas of work and the funding that's been allocated. So on that basis, I think I've said what is necessary to then be able to open up to questions.
Thanks for that, Chris. I'm going to go to Sue first, and then I'm going to invite John in to comment as chair of PFIG, because I know you've scrutinised this business case. So Sue.
Thanks, Chris. I suppose just building on what Chris has just said. So the case before us is for a primary care academy. As Chris has already alluded to, this has been something that has grown, it has evolved, and it has done so in a purposeful way, very much ensure that it can demonstrate its worth, but also demonstrate what it is capable of doing whilst maintaining the level of quality. I think there's three things I want to say. One is, from a VCU point of view, we've already talked about sustainability of our primary care, and not just the sustainability of our current primary care provision, but the increase that we need in order to provide a population health need-based service, driven service. We will need to increase our provision across primary care, and that's not just general practitioners, it is across the whole range of roles, provide care for people in the population. This is absolutely pivotal in terms of our strategic intent to grow our own staff, but also to develop staff across the health kind of ecosystem. The second thing I would say is that it is also part of our strategic intent to really, for want of a better phrase, punch our weight in terms of education and the development of a fantastic educational experience, which also forms part of both our recruitment and retention, as well as our corporate responsibility. And then finally, from my point of view, and I've had the privilege over the last 12 months of being joint chair of the workforce stream, strategic primary care programme at a national level. Work that the Primary Care Academy and Gemma and Claire have done, together with the work that they've been doing across our broader medical education and peace and health sciences, is really, really highly regarded at a national level, and is actually seen as a model that others want to build on. We will only need to see an increase in that, particularly as we look at accelerated cluster development, particularly as we look at decisions taken closer to closer to the person. And I think whilst I recognise that there are concerns about the level of funding, as Chris has said, this is very much on a benefits realisation gateway approach. But I would really want to re-emphasise how this supports our strategic intent as a health board. Thank you.
Thanks for that. So, John.
Thanks, Lucy. Thanks, Chris, for introducing this. I think at PFIG we had some great concerns around this business case, not from what it's trying to do, but more in terms of how it was going to be funded. And I think, although we were very close to rejecting it, the process to get an addendum to clarify things has helped enormously in getting assurance that this is funded appropriately from within existing money from Welsh Government and our existing budgets, and that we're not committing to additional expenditure that was unfunded going past the 23-24 financial year. I think the assurance that there'll be a review process within that time frame as to what we do going forward, I think, is also necessary in terms of making sure we commit to pursuing this. That said, I think there are a couple of questions I've got as well from what we got in front of us in terms of accuracy. One on the sheet, cover sheet, on top of page 2, it talks about embedded documents have been removed because it's something we commented on at PFIG. They haven't been, they're still there. Examples of page 8 and page 13. And then on page 4, with the financial implications section, I still think there's some accuracy there because it talks in terms of but help will evaluate the benefit of the investment ahead of the development of IMTP for 24-27. Well, if we approve the IMTP process that we're going through it as a process now, that'll take us through to 24-25, not 23-24. So any subsequent IMTP will be for years 25 to 28. So the timescale's wrong, I think. But also we were looking for a gateway review process of this business case and what it's delivered, not specifically part of the IMTP planning process. And I'm not sure that's drawn out in what's described there. Over to you, Chris.
Sorry, took a while to come off mute. Yeah, thank you, John. That last point, I agree. I don't believe it is. It shouldn't be suggested that it's part of the IMTP process. It absolutely is, as you've described. I wouldn't expect us to get to a point of 3 years in before doing that gateway review. It has to be a continual process, and as we move through this and and look to increase each stream of activity, it absolutely needs to be upon the benefit of being able to demonstrate its worth in doing so. So if that wording has not come across as well as it could do, or has been misunderstood, I apologise, but I would confirm that it is as you have just said. In terms of the attachments, yes, it does say they have been removed. They should have been removed.
Yeah, and just to come back on that, I think the concern I've got is that through the PFIG process, the process in between and today, it just undermines the validity of the business case and sends concerns around the accuracy of what's in the full case and what's there. So I'm the principle of what we're trying to do here, absolute support, but I'm just worried about the accuracy of it because we're still getting these issues of detail that are not correct.
Do you consider that demonstrating that accuracy is something that we could pick up as we move through the gateways?
Yes, I think so, but we're still in a position where we've got a paper in front of us that we need to approve. So you're accepting what I'm saying, but it's just that concern that I'm slightly nervous.
Okay, thank you for that. I'm sorry, I don't know who came first, Nikki or Richard, but if I bring Nikki in, please.
Thank you, Lucy. So I agree that the need for this expansion is vital for our service delivery moving forward. I have two questions, the first of which links through to what John was talking about. On page 24 of the business case, you've got the measurables in terms of the success of the proposal will be measured, for example, on the number of professionals choosing to follow a career in primary care. But I couldn't see where the pull through was to what that number will actually be. And I would expect in a business case that actually would be demonstrated as a particular number or percentage. Now, it might be that I've missed this, and I was thinking, well, it might actually appear in the IMTP, but very much as John, I sort of think these are two different pieces. So it might be, Chris, that I've missed it, where that information lies.
You haven't missed it, Nikki, in so much as it isn't present there within that business case document. But I think it is implicit, if you're allowed to say implicit at the moment. I think it is implicit within setting that gateway that we have those absolutely in place. And just as you've seen in the IMTP, that move towards a focus upon smart outcomes, I would expect that to be followed through here too.
Okay.
And we'll give that commitment.
Okay, thank you. Then my second question is around the office space for training. One thing that you hear on the ground a lot from the GP practices is that they don't have the space to do this. And I'm just wondering whether what is presented in the business case actually will be enough, and will actually service what is needed.
So the business case focuses upon the academy specific part of that training space. Absolutely, as you say, most of our GP practices struggle for space, and it's regularly a case that's put forward as a reason for not being able to become more involved within training. That's a conversation that continues to unfold on a national basis in terms of primary care estates and what should be allowed and what can't be. It continues to be a developing conversation we're having locally with our LMC, and it will continue to place a draw upon how we choose to use our primary care ring-fenced practice improvement grants. That probably will be insufficient in the longer term, hence the conversations on a national footing.
Thank you, Chris.
Thanks. I know Richard was next, but Joe, do you want to come in on what's just been said?
Very briefly, just to say that one of the improvements we've instigated as part of the current IMTP process is a slightly different approach to business planning templates. This development is an older business plan development taken from the current year's IMTP as opposed to the IMTPs going forward. So some of the issues that have been raised around content and embedding of documents and so on will be resolved by the use of a very different planning template going forwards. So I just wanted to let people know that a piece of work is in train. Thank you.
Thanks, Joe. I'm sure that piece of work will be most welcome to both those of us who have to read the business case and certainly those who have to write it as well. I hope the improvement includes condensing it somewhat. Over to you, Richard.
Thank you, Lucy. I've got 2 or 3 questions, you'll indulge me. Firstly, though, I'd just like to say that I agree absolutely, totally with everything that John has just said, and I also welcome what Joe has just said, which I think would be a positive step forward. The report that we had at committee, which is obviously replicated here, was, to be frank, not the best written report I've ever seen, and the finances of it were somewhat lacking. As John said, we support totally the principle of where the people are trying to get to. That's not an issue. The issue is around the funding and where the money to pay for it is coming from. I welcome the production of the addendum, which moved us forward a bit, not to a complete resolution, and subsequent to that, I think there have been various conversations with Sue Hill around the funding, and as a result of that, I'd just like to ask Sue Hill if she would be so kind as to confirm that there are no unfunded commitments entailed in this up until 2024. That's my first question. Do you want me to pause there, Lucy?
Yes, please.
I'm paused.
Thanks, Richard. So yes, I can confirm that the funding source is agreed and committed for the next 2 financial years. About just under £1 million of it is coming from a recurrent source, and about the balance, which is 2.6 million, is coming out of the strategic support from Welsh Government, which is around transformation. So it's absolutely an appropriate use of the money.
Okay, thank you for that. And I'm sure that hasn't changed much in the course of the last few weeks, but it maybe just exemplifies why the concerns were raised about the report as it was originally presented. Had it been written fully in a financial context, we wouldn't have had these queries. So as I said, I welcome what Joe said about how things are going to develop going forwards. My other 2 questions really about what happens beyond this initial period of time. Clearly the authors of the report, the authors of this proposal, are of the view that and hope that this will prove to be a valuable investment, and one can only hope that that is proven to be the case in due course. But there is a possibility that it might not be proven to be worth taking forward. So my question is around what are our exit strategies for getting out of it, should that prove to be the case. Firstly, about the timing of the review, I'd be grateful if Chris could set out when he anticipates that review being done, when it will reach a conclusion, and when the board or exec team or whoever needs to consider it is able to consider it, so that appropriate decisions can be made then in a timely manner. And secondly, assuming again that it doesn't go forward, what would be our exit strategy for getting out of it, thinking primarily about the various contracts, whether they be staffing contracts or supply contracts that might be entered into to facilitate this in the course of the next few years. How would they be structured so that the board is able to get out of this, if that is the way that it subsequently pans out? Would they, for example, be fixed term contracts? Thank you.
Okay, quite a lot in that. So I think I've written it all down. I suppose first of all, whilst not wanting to prejudge what a review will show, I wouldn't be putting this paper in front of you if I didn't believe in the case that was being put forward. So I am confident that there is, if we do it correctly, a strong return to come from doing this piece of activity. I think it's absolutely appropriate that we demonstrate that rather than give a reassurance, as it were. It is really it's a multi stranded piece of work. There may be some parts of this that are demonstrable in their value, and others that are less so. So, for example, it may be that the training of OTs in primary care is demonstrated to be highly successful, whilst the training of a different set of professionals might then not be. So I think there are, the situation isn't whether or not we would switch it all off or keep it all on, but which streams of activity we would switch on and switch off. And in terms of being able to demonstrate that, they will be at various different points in time. And so I think what I'm saying is it is a serial piece of work that needs to continue on a rolling basis rather than it being a single gateway. In terms of the investment, most of the investment is in terms of training posts. If we're not training individuals because the benefit of training them has not been demonstrated and we have ceased that, then so too the cessation of the funding. And most of these training posts, perhaps not all, but most of them are in terms of 12-month or less periods, and so fall in year as we work through. There will be some costs that aren't related to those training posts, of course, but in the same way as all of our investments that we enter into, where we expect them to continue. When a benefit is not demonstrated, then we need to look at that service and establish the disinvestment programme according to what we see in front of us. I feel as if I'm giving you a little bit of a vague answer there, but it's difficult because there are multiple strands within this, and it isn't simply a case of switching the whole lot off or keeping the whole lot running. But I would be happy to have a conversation about how some of those would work through upon on paper, though probably not within the scope of today's timescales.
Okay, thank you very much for that. I'm a little unclear though how, given that we're in 2-3 years' time, we'd be into a period of time when there is no funding currently identified. How we would be assured that we had successfully withdrawn from all activities and costs, if that is the way that it pans out? I accept what you said at the beginning of your answer, that you have confidence that it will demonstrate its worth, and that I'm sure will probably be the case. But just in case things don't work out that way, if we're looking at everything in a series of different strands at different times, with lots of different commitments that expire at different points, I'm not sure how we have an effective exit strategy that gets us out of these ongoing costs if needs be.
I'm not sure with many of the business cases that we put forward that we have a clear exit strategy that is identified quite that explicitly at an early point, because it's an evolution. I think the commitment to doing the gateway reviews and being clear that we no longer continue to fund something that isn't demonstrated to be a worthy enterprise is the essential part, and the part that I would be 100% committed to. Many of these programs that are running are already demonstrating their worth. What they're not demonstrating is their volume, and much of this is about volume as opposed to continued innovation. So there is a high confidence in putting this in front of you, that these courses of action will positively contribute towards the sustainability challenges that we've already heard about today in terms of primary care. I'm not sure I can provide any greater detail than that today.
Okay, thanks for that, Chris. And on the basis of what you said, I, for one, I'm content to support your proposal here. All I would ask, though, is that Jo, in taking forward her review of business cases, how they're structured for the future, takes into account the concept of exit strategies where relevant, and builds that into the process. that's for a different discussion for a different time. Thank you, Lucy.
Thanks, Richard. We really are pressed for time. If I bring Sue and John in, and then we're going to have to make a decision.
Actually, so I just wanted to provide a little bit of additional information to that Chris had put forward, particularly around the infrastructure, which are the costs that we would need to exit from, because there's the rest, as Chris said, is primarily on trainees. We're not receiving trainees or supporting trainees, then we wouldn't spend the cost. We're going through a piece of work at the moment, particularly around the integrated medium-term plan, to understand how the academy can fit in with a wider education infrastructure. We've already identified the demographics and the risk mitigation for the key posts, particularly those non-clinical posts. Those clinical posts, the board will all know that we're not short of vacancies for nurses and medics, and as we talked about, GP. So in terms of the clinical staff, confident that if we were to move away from the academy, we would be able to suitably redeploy clinical staff. We're also working through an age profile with our education infrastructure to ensure that we could mitigate the risks of our non-clinical staff. But I think we need to see the context of wider educational infrastructure. When we look at that and the proportion of people that would need to be deployed if the academy were to no longer be required, given the size of the organisation, given the size of the turnover, I think the risk is easily mitigated, but clearly we need to outline that in the plan.
Thanks, Sue. Would part of that be, because one of the things I highlighted was the Health Board does not have a workforce plan for the recruitment and deployment of these professionals. So is that the part of the piece of work you're referring to?
Yes. Yes.
Okay, thank you very much. There's loads I could say about this business case, but you'll be pleased to hear most of it is more about the strategy and the implementation of this plan and the whole academy workforce, rather than actually the business case itself. So I'm not going to go into any of that today. I'm sure we can pick that as offline as we move forward with this piece of work. So there are right, sorry, just noting a comment there from John. So there are some queries about some of the information that's been presented to us today, some gaps that have been identified, recognising that some of it has not been ideal, and we've talked about the format of the business cases going forwards being changed. Are the board basically sufficiently satisfied to be able to support the business case today, taking into account some of those reservations based upon what we've discussed? Because that's fundamentally the decision we've got to have. So are we supportive of the business case today?
Yes.
Just, but only just.
Yes.
Yes.
Okay, so just about with reservations, Chris, but I'm sure there'll be ways in which we can try and tighten that up, and how that's going to be monitored in future.
Absolutely.
John Glanders. Have you got your hand up, John?
Apologies, old hand, turn it down now.
Okay, thank you very much. So that the business case has been approved then for progressing the primary and community care academy. Thanks very much. So we've got, we're almost there, folks. The Audit Wales Structured Assessment and Annual Audit Report is the next item on the agenda. Andrew Doughton, unfortunately, is unwell, so is not able to present this item to us. And they have asked Louise and I if we are content to accept the report for noting, which we have agreed to do. Louise, is there something you just want to say? I'll give you 1 minute.
No, not particularly, and very conscious of time. I mean, colleagues and board colleagues have had a good discussion on the structured assessment, particularly at the last board workshop. So there's, so we have done that, and the audit report is just the additional piece there. But again, a lot of that was actually touched upon in the structured assessment. So I would commend it to the board today.
Thanks for that, Louise. I would just like to comment that this is the most positive structured assessment report that we've had from Audit Wales since I began with the Health Board. So particularly recognising the difficult time we've had in the last couple of years and the challenges, I think this really does demonstrate the progress that the organisation has made. Richard.
Thanks, Lucy, and sorry for clogging up the time process again. I think let's be fair. This is a good report compared with history, and we need to be positive and recognise progress when progress has been made. So I think it's a case of congratulations to everybody who has been involved in and instrumental in developing this. That's not to say we can't do better and go further, but it's a very good first step. My one query is on the one of the issues raised by the auditors was that a number of declarations of interest relevant to the financial statements had not been made. Declarations of interest are a key part of a governance process. They're essential for transparency, and I'm a little concerned that a number of them are, or at least were when this was written, outstanding. So my question is to whomever how many are outstanding, were outstanding, are they still outstanding, and what can we do to ensure that the comparatively simple and straightforward process of doing a declaration of interest is done more expeditiously next time round?
Thanks. Before I bring Louise in to answer that, I would say actually I think that the system that is used for making those declarations is actually really difficult, clunky, particularly if you're not in the office on a daily basis. I think that is fundamentally the problem. You have to know what your login details are, and rather than I'm used to just being given, being asked, can you make your declaration of interest? And I suspect that's what the problem is.
Well, may well be the case. Where I've done it previously, it's just been a matter of signing a piece of paper and handing it over, and that was it.
That's the problem, Richard. It's far more complicated here, but and John's given a thumbs up on that. So, Louise.
Yeah, I'm very happy to talk to you, Richard, outside of the meeting about some of the process improvements I've got in mind for that, because I think it was a bit of a system issue concerning that, because it meant that people weren't reminded in a timely way, I think, to make those declarations. Now that has been rectified, and you will see the full list of the declarations in the annual report which we produced last year. But actually Internal Audit are doing a bit of a piece of work on this for us at the moment, which is being really helpful. So it is a bit of a process piece. There's lots we can do more around our general approach to declarations of interest across the organisation, but I'll happily chat to you a bit more about some of that outside the meeting, if that's okay.
I'm happy to short circuit it there, Lucy, in the interest of time. Could we just add this as an action point and maybe have something at the next board meeting?
Thanks. Yes, indeed.
Thanks very much.
Okay, thank you. We now move on to research and development annual report. Nick, I believe you're the lead for this. Are we able to note this in the interest of time?
It's a good news story. Happy to take any questions outside, Lucy, but happy to note it if members are happy.
Thank you very much. We have read it, and so we're happy to receive it. Are there any questions? No, that's great. So thank you very much for that. So we've I don't think there are any specific items to refer to committees, but I will go through that with Philippa outside of the meeting when we review the minutes, just to make sure. We have review of risks highlighted within the meeting. I think we've discussed some of those specific ones, and again we'll make sure that those are clearly documented. I'm going to suggest, in the interest of time, that we pick up on any feedback on the meeting effectiveness outside of the meeting, so we can take those forward. We then have the summary of private board business to be reported in public, where we're asked to note the report, which we so do. And the date of the next meeting then is the 10th of March 2022 rather than 2021. And then we move on to exclusion of press and the public, that representatives of the press and other members of the public be excluded from the remainder of this meeting, having regard to the confidential nature of the business to be transacted. And we move into private session. So thank you very much to everyone. We will finish the public meeting at this point and dial off and dial into